and welcome to the Megagen 2026 Eurasia Continental Round Live. My name is Kasyan Roman, and I am one of the 2023 Megamind winners. It's truly meaningful to be here today, not as a contestant this time, but as your host. And I still remember how intense it felt to prepare for this stage, the pressure of building the right case, respecting the timing, and delivering an idea that actually matters. It is a hard work, and there are no shortcuts, but I can tell you from my experience, worth it. So, standing here and sharing your vision with your colleagues is both a privilege and a responsibility. You are not just presenting a case, you are contributing to how we learn from each other as professionals. And that exchange of ideas, experience, and perspective is what makes this profession unique. So to all of our participants, you've already earned our respect. Everyone, please give our contestants a big round of encouragement. And the goal of the Megamind is to search for and cultivate the next leaders of global education. So each participant will deliver a 15-minute presentation showcasing an implant-focused case and their approach, from diagnosis and planning to execution and follow-up. The presentations will be evaluated based on the purpose and clarity, on clinical impact and novelty, the case workup and documentation, ethics, and evidence-based rationale, as well as the structure, visual quality, the communication, and the audience engagement. So each participant will deliver a 15-minute presentation, and how well you manage their time will also be a part of the evaluation. Now, it's my honor to introduce our judges. So please welcome Dr. Julian Filipov from Michelangelo Medical Concept, Dr. Kelvin Afrashtefar, University of Bern, Department of Reconstructive Dentistry and Gerodontology. Thank you for joining us and providing a fair professional evaluations today. And today we are proud to welcome our contestants for the Continental Round Eurasia League. Dr. Gurgen Khachatrian, Russia. Dr. Kristina Medvedeva, Russia. Dr. Fakhraddin Huseynov, Azerbaijan. Dr. Hikmat Bakhishov, Azerbaijan. Dr. Anton Dabrytski, Belarus. Dr. Nailja Idrissova, Estonia. Dr. Antons Vostroilovs, Latvia. Dr. Marius Svedas, Lithuania. Dr. Bertalan Nemeth, Hungary. Dr. Maros Kopacka, Slovakia. Dr. Jakub Kwiatek from Poland. Dr. Marcel Firlej, Poland. One more highlight for today. This is a live global event and an historic moment for the Megamind. For the first time in the competition history, we are using a real-time AI interpretation system to create a truly global stage, where great implant clinicians can present and be understood without any language barrier. You can simply scan the QR code on the screen, select your preferred language, and enjoy every presentation in real time. And if you want to support your favorite speaker, you can cast your vote during or after the competition on the official website globalmegamind.com. Alright, welcome once again to the Megamind 2026 Continental Round Eurasia.
Добрый день, меня зовут Хачатрян Гурген. Я стоматолог-ортопед, хирург, имплантолог и являюсь главным врачом и основателем авторской стоматологии «КосмоДент» в городе Томске, Россия. Моя клиническая практика сосредоточена на комплексной реабилитации пациентов с выраженным дефектом зубочелюстной системы, где требуется сочетание хирургических, ортопедических и биологических методов восстановления. В представленной работе я хочу продемонстрировать междисциплинарный подход направленный на достижение функциональной и анатомической и эстетической гармонии. Мой практический опыт составляет 13 лет. Я специализируюсь на имплантации, костно-реконструктивных операциях, тотальном протезировании. В своей практике применяю полностью цифровой протокол, обеспечивающий высокую точность, предсказуемость и воспроизводимость хирургических и ортопедических этапов лечения. Использование цифровых технологий позволяет минимизировать хирургическую травму, оптимизировать позиционирование. Трансплантация посвящена применению аутотрансплантации зубов в сочетании с аутогенной костной пластикой у пациентов с диагнозом «𝐬𝐧𝐝 𝐒𝐞» при реконструкции переднего отдела верхней челюсти с использованием современных методов цифрового анализа, 𝐂𝐔𝐑𝐀 и 3D-моделирования. Врожденная 𝐬𝐧𝐝 𝐒𝐞 и дефекты альвеолярного отростка создают значительные сложности в восстановлении эстетики и функции переднего отдела верхней челюсти. Нарушаются контур альвеолярного гребня, формируется дефицит мягких тканей и изменение положения зубов, и нарушается окклюзионная стабильность. Традиционные методы реконструкции костной ткани и мягкой ткани часто сопровождаются длительным заживлением, риском резорбции трансплантанта и ограниченной предсказуемостью в эстетическом результате. В этом контексте биологическая реконструкция основана на сохранении периодонта и жизнеспособности тканей трансплантируемого зуба, позволяет поддерживать физиологическую архитектуру альвеолярного отростка, улучшить эстетику, формировать оптимальные условия для последующей ортопедической реабилитации. Цель нашей настоящей работы – продемонстрировать практический протокол биологической реконструкции у пациентов с 𝐬𝐴 губой с применением современных хирургических и биологических и цифровых технологий. Точное трехмерное положение донорского зуба является критическим фактором, влияющим на приживление, сохранение мягких и твердых тканей, а также окончательный эстетический результат. Первое – это вертикальное положение, когда корень располагаем мы на 1-2 мм апикальнее цементоэмалевой границы соседних зубов, что обеспечивает физиологический контур десны и формирование эстетического биологического пространства. Второе – это букально-язычное положение. Трансплантант размещается по центру альвеолярного гребня с возможно небным наклоном для сохранения толщины вестибулярной костной пластинки. Третье – это медиальное расстояние не менее 0,5 мм от соседних корней для сохранения перинатальной связки и нормальной васкуляризации. Четвертое – это осевая нагрузка соответствует длинной оси зуба, что обеспечивает равномерное распределение жевательной нагрузки и снижает риск резорбции. Фиксация. Пятое. Временная стабилизация в течение 2-4 недель необходима для реваскуляризации. Но в данном клиническом случае, который я покажу дальше, фиксация была продлена до 2 месяцев, в связи с чем мы провели трансплантацию зуба с костной пластикой. И строгое соблюдение данных принципов обеспечивает биологическую интеграцию трансплантанта, стабильность тканей и гармоничную реконструкцию альвеолярного отростка. Реконструкция зуба и альвеолярного отростка у пациентов с 𝐬𝐴 губой требует многоэтапного и тщательно планированного подхода для достижения стабильного функционального и эстетического результата. Первым этапом проводится клиническая оценка, анализ 5 типов десны, толщина слизистой оболочки, уровень прикрепленной десны, состояние пародонта и выполняется фотопротокол. Это позволяет определить зоны дефицита тканей, спрогнозировать контур мягких тканей и оценить влияние дефекта на архитектуру зубного ряда. Следующим этапом является рентгенологическая диагностика. Панорамные и прицельные снимки дают представление о положении соседних зубов, состоянии корней. Конусно-лучевая компьютерная томография обеспечивает трехмерную оценку объема кости, ее плотность, анатомических ограничений и пространственной конфигурации дефекта. На основе полученных данных создается цифровая модель донорского зуба и принимающего ложа. Виртуальное планирование позволяет определить оптимальное положение трансплантанта, угол наклона, глубину посадки и прогнозировать объем необходимой костной реконструкции. При необходимости изготавливаются 3D-печатные хирургические шаблоны, обеспечивающие точность, подготовку ложа, снижение травматичности операций и сохранения жизнеспособности периодонта. Выбор донорского зуба основывается на сохранении корневой поверхности, целостности цемента, состоянии периодонтальной связки и нарушения соответствия дефектам. Такой подход обеспечивает точное позиционирование трансплантанта, сохранение мягких и твердых тканей и формирование стабильного эстетического гармонического результата. Рассмотрим клинический пример отложенной аутотрансплантации зуба в позицию 2.2, трансплантации зуба 3.5 в позицию 2.2. У пациента с дефектом переднего отдела верхней челюсти в области зайчьей губы одновременно с трансплантацией выполнялась костно-пластическая реконструкция, направленная на восстановление алвеолярного отростка и формирование костной опоры и поддержку естественных контуров мягких тканей. Пациент прошел полный цикл предоперационной диагностики, включая клиническую оценку биотипа десны, состояние мягких тканей и объем костного дефекта, а также 3D-томографическое обследование. Цифровое планирование позволило определить оптимальный угол наклона трансплантанта, глубину посадки, позицию в трехмерном пространстве и необходимый объем костной реконструкции, что позволило минимизировать риск травмы тканей и повысило предсказуемость эстетического результата. До хирургического вмешательства пациент долгое время носил съемный протез, что не обеспечивало достаточную эстетику, комфорт для пациента и не обеспечивал стабильность мягких тканей и не предотвращал прогрессирование костного дефекта. При клиническом осмотре и анализе КЛКТ выявлен костный дефект, включающий выраженную потерю мягких и твердых тканей. Здесь мы видим на компьютерной томографии, что отсутствует костные ткани, идет сообщение полости рта с полостью носа, отсутствует дно носа, полностью вестибулярная стенка и небная стенка. Мы видим здесь горизонтальный и вертикальный дефект. А также мы видим в полости рта сообщение ротовой и носовой полостей. Это состояние, требующее комплексного подхода. Выбор донорского зуба является критическим на этом этапе планирования, поскольку анатомическое соответствие трансплантанта напрямую влияет на стабильность, васкуляризацию и долгосрочный прогноз. Изначально в качестве донорского зуба рассматривался зуб мудрости верхней челюсти, так как он обладает достаточным объемом корневой структуры и часто используется при аутотрансплантации. Однако при цифровом анализе и сопоставлении с объемом костного дефекта было выявлено, что размеры третьего премоляра слишком большие и не подходят под донорскую зону. Использование зуба с избыточным корневым объемом могло привести к чрезмерному давлению на стенки ложа, компрессии периодонта, нарушению реваскуляризации и повышенному риску резорбции и анкилоза. Кроме того, несоответствие формы геометрии корня затрудняло бы достижение правильного трехмерного позиционирования и стабильности мягких тканей. И в связи с этим предпочтение было отдано зубу 3.5, который обладал оптимальным соотношением размера корня и объема дефекта, благоприятной анатомической формой и сохранением периодонта. Его морфология позволяла обеспечить терматическую установку, равномерное распределение нагрузки и адекватную стабилизацию и формирование физиологического контура алвеолярного отростка. Таким образом, выбор зуба 3.5 был обусловлен анатомо-биологическим соответствием, что повысило предсказуемость приживления и долгосрочную стабильность реконструкции. На хирургическом этапе были выполнены вертикальные и горизонтальные разрезы, сформирован слизистый надкочечный лоскут для полной визуализации дефекта контроля анатомических ориентиров. Мы полностью откинули лоскут, увидели полностью размеры дефекта и далее приступили к примерке 3D-модели зуба в принимающей ложе с целью проверки точности подготовки и пространственного соответствия. После чего зуб 3.5 был травматично удален, сохранением периодонтальной связки и без повреждения корня зуба, и немедленно трансплантирован подготовленное ложе. Далее мы произвели забор блоков с бугра верхней челюсти, насколько это было возможно. Мы забрали хороший объем блоков, уложили все вокруг зуба со всех сторон, и один блок зафиксировали в дно носа. И с помощью пинов мы зафиксировали по модифицированной технике B2S, обеспечивающей хорошую стабильность трансплантанта, и восстановили объем полностью аллеолярного отростка. Следующим этапом мы мобилизировали лоскут и наложили нерассасывающиеся швы. Выполнили шинирование для обеспечения первичной стабильности трансплантанта. Одновременно в области донорского зуба 3-5 мы установили имплантант для последующей ортопедической реабилитации. Через 4 месяца мы провели постоянное протезирование коронкой из диоксида циркония, что обеспечивает высокую прочность и эстетическую интеграцию. Через 2 месяца терапевт нашей клиники проводит эндодонтическое лечение с последующей герметичной обтурацией каналов, после чего выполняется эстетическая реставрация зуба 3-5, превращаем в зуб 2-2. Обеспечивает, которые восстановили коронковую часть, и анатомическую форму и цвет зуба. Через 13 месяцев наблюдалась небольшая рецессия, и было принято решение сделать мягкотканную операцию, закрыть рецессию с помощью трансплантанта верхней челюсти, с неба, для улучшения толщины мягких тканей и стабилизации десневого контура. Через 2 года наблюдается полная стабилизация мягких и твердых тканей, восстановление анатомического контура аллеолярного отростка, полное закрытие сообщения полости носа с полостью рта, что подтверждает успешность, долгосрочную стабильность и высокий эстетический уровень реконструкции. И данный случай демонстрирует, что отложенная аутотрансплантация зуба в сочетании с аутогенной костной пластикой является эффективным методом реконструкции переднего отдела верхней челюсти у пациентов с врожденной расщелиной верхней челюсти. Ключевым аспектом является сочетание нескольких важных сложных задач: восстановление объема аллеолярного отростка, закрытие ороназального сообщения, сохранение мягких и твердых тканей и точное трехмерное позиционирование трансплантанта на основе цифрового планирования. При применении модифицированной техники B2S, автоматической трансплантации, цифрового планирования и последовательной реконструкции мягких тканей позволило достичь стабильной интеграции трансплантанта, высокой функциональности и выраженный эстетический результат. Представленный клинический пример подтверждает, что интеграция современных цифровых технологий и биологического подхода значительно расширяет возможности реконструкции реконструктивной хирургии в эстетически значимой зоне. Такой подход позволяет решать сложные клинические задачи, снижать риск осложнений, повышать предсказуемость лечения и достигать долговременной стабильности как функциональных, так и эстетических результатов. И данная операция всего лишь по срокам заняла всего 4 месяца. Это достаточно быстро для такого объема реконструкции, когда классические методики позволяют это делать в течение 1,5-2 лет. Все, я закончил. Спасибо.
Recording stopped.
Thank you for your presentation.
Спасибо.
Okay, the judges, any comments?
Thank you so much, Dr. Gurgen. It was a really nice presentation. You just emphasized the importance of biology in dealing with such complex cases. And I would have just one question. How do you see any other possibilities to manage this kind of defects when you have palatoschisis, exactly the case you just presented? I mean, if you don't take into account to make a tooth transplantation and you consider to place an implant in that particular case, how would you approach it, and how do you see the benefits in relation to the approach you just showed us?
Так, проблема была то, что пациент был молодой, и ему всего лишь было 17 лет на момент обращения, поэтому мы выбрали такой аутологичный подход для его решения его проблемы. А если это взрослый пациент с проблемой с расщелиной верхней челюсти, то одним из вариантов лечения это является костная пластика с использованием костных блоков с нижней челюсти, методика доктора Кури. И последующие через полгода, через 4-6 месяцев установка имплантанта. Далее через 4 месяца раскрытие имплантанта пластикой мягких тканей и установка временной коронки, потом постоянной коронки.
Okay, thank you so much. It makes sense. Thank you so much once again.
Спасибо.
What about Professor Calvin?
Yeah, you mentioned that you use Dr. Curry's method. Did you actually use some bone plates?
В данном клиническом случае я использовал костные блоки только с бугра верхней челюсти. А вообще в других клинических кейсах я использую методику доктора Кури с использованием блоков с нижней челюсти.
Okay, thank you.
Okay, thank you, judges.
Жюри, участники конференции. Меня зовут Кристина Медведева. Я рада приветствовать вас на конкурсе Megamind 2026 и предоставить вашему вниманию клинический кейс на тему восстановления межопроксимального костного и десневого дефекта при одномоментной имплантации во фронтальной зоне зубов. Я являюсь хирургом-стоматологом, имплантологом, пародонтологом, веду ортопедический прием, являюсь лектором и опион-лидером компании Megagen Россия. Я работаю в городе Челябинске и веду свой клинический прием с максимально комплексным штатом специалистов высокого класса профессионалов, также ассистентов, которые помогают нам выполнять все необходимые комплексные мероприятия для реализации наших возможностей с пациентов, наличия собственной лаборатории в нашей клинике для достижения максимально эстетичного результата. С какой же проблемой мы сталкиваемся на нашем приеме при работе с пациентами? Это проблема эстетической зоны, которая является максимально сложной при проведении имплантологического лечения. И в данной ситуации при работе во фронтальной зоне важен каждый нюанс. Это миллиметр кости, формирование ткани, толщина ткани, положение имплантанта. И все это оказывает влияние не только на стабильность имплантанта, а также на результат, который ожидает пациент. Это и будет идеальная улыбка или компромиссное лечение. Проводя работу в эстетически значимой зоне, мы не имеем права на ошибку. Мы должны добиться максимально быстрого, эффективного и эстетичного результата. В нашей практике мы начали часто встречать осложнения при проведении одномоментной имплантации, которые связаны с состоянием вертикального и горизонтального дефекта после получения травм во фронтальном отделе, а также получения осложнений в виде хронического периодонтита и наличия костных изменений. Во фронтальном отделе мы наблюдаем более 80% травм по сравнению с другими отделами челюстно-лицевой области. И встает ключевой вопрос: можем ли мы одномоментно восстановить вертикальную, горизонтальную резорбцию, а также восстановить межопроксимальное костное и мягкотканное пространство быстро, эстетично и предсказуемо, и самое главное, с минимальным вмешательством в одно посещение? Да, мы можем, в один визит мы можем получить стабильный результат. Каким образом? Вы видите исходную клиническую ситуацию на рентгенограмме, где мы видим изменения вестибулярное, межопроксимальное, небное и стабильную кость после проведения имплантологического лечения. Если мы будем говорить про статистику наличия вертикальных дефектов во фронтальной области, она достигает до 60%, и более 5 мм – это сложные дефекты, которые составляют до 30%. Также 15-25% – это горизонтальные дефекты около 4 мм, которые в свою очередь составляют больший процент, до 70% по сравнению с вертикальной резорбцией. Итак, вертикальные и горизонтальные дефекты также могут сопровождаться с нарушением межопроксимального пространства. И это крайне сложная ситуация во фронтальной зоне. И в нашем клиническом кейсе было нарушение наружной кортикальной пластинки, небной кортикальной пластинки, также нарушение интерпроксимального пространства как медиально, так и дистально по отношению к соседним зубам. То есть наша задача была восстановить дефект фронтальный, а также восстановить жизнеспособность и состояние костной ткани в области самих зубов. Когда мы говорим про характеристики эстетической зоны, самым важным показателем является структура наружной кортикальной пластинки, небной кортикальной пластинки, которая является ключевым фактором в эстетической стабильности как костной ткани, так и десневого состояния. Интерпроксимальная кость является важным ключевым моментом в восстановлении межзубного пространства десневого, а также в сохранении и восстановлении десневого контура. Восстановление межопроксимального пространства является очень важным и ключевым моментом в эстетической работе во фронтальной группе зубов. Почему? Потому что является регенерацией костной ткани в области имплантанта, в области соседних зубов, которые имеют такой же костный дефект. Они являются точкой роста остеобластов и остеокластов и формируют межопроксимальный сосочек с медиальной дистальной поверхности. Клинические факторы, которые влияют на успех нашего клинического случая, это планирование и позиционирование имплантанта, это формирование мягких тканей, формирование костных тканей путем регенерации костной, а также оценка наружной кортикальной пластинки, небной пластинки и межопроксимального пространства. Моя цель не показать красивый результат и эстетичный результат. Моя цель поделиться этапами, которые привели к успешному результату в сложной ситуации, которые помогают минимизировать количество хирургических вмешательств, снизить количество осложнений и привести к эстетическому результату на благо здоровья наших пациентов. Клинический кейс: пациент, 42 года, была получена травма фронтального отдела более 8 лет назад. Около 5 лет пациент не наблюдался в клинике, не имеет хронических заболеваний, не курит, но имеет огромную возможность проведения реконструкции переднего отдела. Это исходная клиническая ситуация верхней челюсти, где мы можем наблюдать причинный зуб 1.1. Мы проводим 3D-диагностику и видим изменения во фронтальном отделе. Затем детальное обследование стоматологического статуса, которое показывает изменения в области центрального резца и соседних зубов, где мы наблюдаем трещину, перелом зуба, мы наблюдаем дефект в области межопроксимального пространства слева-справа и горизонтальную резорбцию. Проводя клиническое обследование, был составлен план лечения, который включал в себя пародонтологическую терапию в процессе хирургического и после лечения для динамического наблюдения, проведение навигационной хирургии, проведение удаления зуба 1.1, забор костного блока в области угла нижней челюсти с последующей сегментацией на ламины, также установка имплантанта Any1 в область отсутствующего зуба, проведение костной аугментации и мягкотканной аугментации для достижения максимально эстетичного результата, также изготовление временной и постоянной коронки. Материалами и методами являлись постоянная коронка это диоксид циркония, временная коронка ППМА, проведение мягкотканной пластики с помощью забора трансплантантов с бугра верхней челюсти, также с неба при повторной коррекции, о которой я расскажу позже, и использование аутокости в виде ламины и в виде костной стружки. Материалы и методы: было проведено удаление центрального зуба и установка имплантанта в область отсутствующего зуба Any1. Время хирургического лечения заняло 4 месяца до момента постоянной конструкции. Период долгосрочного наблюдения более 2 лет. Было проведено планирование установки имплантанта 1.1. Также мы видим хирургический шаблон. Было проведено тщательное удаление зуба 1.1, и он оказался подвижным отломком. Далее было проведено удаление апикальной части зуба 1.1 с его последующей сегментацией, где мы видим в области удаленной лунки большое количество грануляций, апикально, небно и межопроксимально, которые были в последующем удалены, фиксация хирургического шаблона, использование имплантанта в область удаленного зуба диаметром 4,5 на 13 мм, и установка с помощью хирургического шаблона. Мы получили торг, момент вкручивания имплантанта 60 ньютонов, что дало нам возможность в последующем запротезировать временной коронкой в момент посещения пациента. Также был проведен забор ламины в области нижней челюсти справа. Вы увидите на правом участке слайда это забор костного блока и небольшое количество аутокости. Затем была проведена тщательная сегментация. Костный блок был небольшого размера, он был до 10 мм в диаметре, до 8 мм в ширине. Далее он был сегментирован на 3 части по 2, 4 и 2 мм. Также в последующем он был сегментирован на 2 части по своей длине для того, чтобы фиксировать его вестибулярно, фиксировать его небно и участок 1 и 3, которые составляли 2 мм, были использованы для медиально-проксимальной позиции и дистально-проксимальной позиции, для того, чтобы восстановить межопроксимальные контакты. Что мы видим? Мы фиксируем наши ламины в вестибулярном, в небном положении, фиксируем с помощью бинтов и также адаптируем костную стружку. Здесь мы видим, как мы адаптируем медиально-проксимальную. Это идет в процессе вколачивания в отсутствующую кость между зубом и между имплантантом. Медиально. Затем также происходит вколачивание костного сегмента в области дистальной позиции и восстановление наружной и кортикальной ламины при установке имплантанта. Был проведен забор десневого трансплантанта в области бугра верхней челюсти, затем его последующая деэпитализация, использование десневого трансплантанта после проведения направленной костной регенерации. И мы видим контрольный снимок, где мы можем обратить внимание, насколько отчетливо видны положения наших костных ламин в межопроксимальных контактах между зубом и между имплантантом, медиально и дистально. Далее мы изготовили временную коронку и в это же посещение зафиксировали пациенту в область имплантанта. Пациент ушел с максимальной эстетикой после проведенной операции. Так как мы имели большой торг, мы имели возможность нагрузить имплантант и не получить осложнения. Затем мы видим контрольный снимок через 3 месяца, где у нас стабильная костная ткань в области имплантанта, и также у нас стабильный уровень мягких тканей в области имплантанта, в области зубов. Но мы получили хороший объем мягких тканей, хорошую ширину, плотное прилегание, но мы можем увидеть, что в области межсосочка, в области имплантанта и в области центрального зуба недостаточный объем межопроксимального десневого пространства для положения сосочка. И в области зуба 1-2 вестибулярно. Здесь мы видим, что разный уровень высоты, и добиваясь хорошего уровня эстетики, мы планируем сделать коррекцию перед установкой постоянной конструкции. Мы проводим забор трансплантанта. В данной ситуации, так как нам надо было ликвидировать рецессию в области неба, забор трансплантанта был произведен в области неба. Проводится его деэпитализация, убираем лишние ткани, выравниваем края и используем трансплантант уже непосредственно в области имплантанта и в области зуба, для того, чтобы скорректировать десневой контур. Что мы видим? Результат через месяц на временной и на постоянной, на временной конструкции в области зуба и в области имплантанта. И оцениваем состояние мягких тканей, состояние сосочка, состояние мягких тканей в области зуба, и оно прекрасно. Прекрасно за счет того, что мы достигли полностью эстетический уровень восстановления межопроксимального контакта в области имплантанта и в области 2 соседних зубов. Мы получили сосочки, которые максимально выросли, которые стабильны более 1,5 месяцев. Мы оцениваем состояние десны, контур, объем, цвет, структуру, а также интропроксимальное заполнение. Здесь мы видим перед постоянной конструкцией состояние мягких тканей, которые мы оцениваем, десневое ложе, состояние межопроксимального пространства. Изготавливаем постоянную конструкцию, коронка из диоксида циркония, контрольный снимок через 4 месяца. И мы оцениваем состояние кости в области забора нашего небольшого десневого блока, и оно идеально, полное восстановление костной ткани. Затем мы оцениваем состояние кости через 2 года после проведения. У нас полностью сохранены пики в области имплантантов, пики в области имплантанта и в области зубов соседних, и с одной, и с другой стороны. Это прекрасный результат. Мы внимательно оцениваем состояние костной ткани на срезах, на аксиальных срезах, где мы видим на всю длину имплантанта полную стабильность костной ткани, и также медиальное и дистальное перемещения на срезах в 1 мм состояния кости в области имплантанта. Клиническая ситуация до и после более чем 2 года. И эстетическая клиническая оценка коронки через 2 года полностью устраивает пациента и доктора. В один визит мы могли получить стабильный результат, сделать одну хирургическую манипуляцию, которая дала нам возможность возместить много дефектов за один раз. Делая выводы, можно сказать, что мы получили стабильность имплантанта при проведении одномоментной операции имплантации с восстановлением вестибулярного, горизонтального и межопроксимального дефекта сразу с временной коронкой и отпустили пациента с эстетическим результатом. Также возможно проведение восстановления вестибулярной, небной, межопроксимальной кости с использованием тонких ламин, которые дают возможность использования аутокости для достижения эстетичного результата. И восстановление мягких тканей дает огромную возможность при полном восстановлении межпроксимального контакта, который у нас получилось достичь. И я очень рада данному результату вместе с пациентом. И благодарю вас за внимание. Спасибо большое.
Recording stopped.
Thank you for your presentation. So the judges, any comments?
Thank you so much, Dr. Medvedeva.
Yeah.
For me, everything is clear. I enjoyed your presentation. So congratulations for your exposure and for your the way you presented.
Thank you so much.
I wish you good luck forward. Thank you so much.
Thank you very much. And pleasure. Thank you.
Thank you, Kristina, for your excellent presentation. I hope next year you give it in English as well. You're very talented with the presentation.
Yeah. Thank you very much. I know the English, but in Russian, maybe because in my country it's first time in this round. Okay. Thank you so much.
Little by little. I wanted to ask you,
Yeah.
in terms of the soft tissue graft, you did it at 2 different time intervals, or it was done only once?
Спасибо за вопрос. Это было дважды. Объясню почему. Первый забор был забор трансплантанта с бугра верхней челюсти при проведении установки имплантанта и проведении костной пластики. За счет того, что произошла все равно усадка, мобилизация мягких тканей, мы хотели получить максимально эстетичный результат, и нам не хватало 2 мм для максимально ровного контура, максимальной эстетики. Пациент был счастлив, всего было достаточно, но так как мы стремились к максимально красивому эстетичному результату, мы забрали перед постоянным протезированием, перед изготовлением коронкой, в моменте там сканирования, я забрала лоскут с неба, провела его деэпителизацию и сделала туннельным способом перемещение трансплантанта как в область соседнего зуба, так и в область имплантанта. И это дало мне прекрасный результат, что мы минимизировали рецессию, я еще больше утолщила объем мягких тканей в области имплантанта, что дало мне прекрасный результат и, самое главное, сформировало сосочки на максимальную высоту, что является невероятным при отсутствии межпроксимального контакта изначально.
Okay, thank you for your answer. Good luck.
Yeah, thank you so much. Thank you very much.
Okay.
времени суток, уважаемые коллеги. Зовут меня доктор Fakhraddin Huseynov. Родился, учился, работаю в городе Баку, Азербайджан. Занимаюсь имплантацией с 2008 года, немедленной нагрузкой с 2015 года, 2017 года, извините, 2017 года. Как известно, современные тенденции, современные стандарты подразумевают собой реабилитацию пациентов с немедленной нагрузкой. Жизнь без зубов в современном мире социально активным людям очень сложно. Поэтому хотел бы представить вам клинические случаи с использованием имплантов Megagen Anyridge с пациентами тяжелой атрофии верхней челюсти. Два клинических случая с использованием имплантов Anyridge. Как мы знаем, что в данное время используются в основном две методики. Это аугментация с последующей имплантацией и использование угловых имплантов, no graft, без использования искусственной кости. На верхней челюсти это обход синуса. Импланты используются птерygоидные, зигомы и установка имплантов в назальную кость. Дизайн имплантов Megagen Anyridge практически в любой ситуации позволяет нам реабилитировать пациентов с использованием временных зубов. Пациентка обратилась, 62 года пациентки. Как вы видите, очень сильная атрофия кости, периапикальные изменения, подвижные конструкции. На первом этапе мы удалили все зубы и изготовили пациентке съемные протезы. По истечению 6 недель, как мы видим, очень сильная атрофия, практически нулевая кость под синусами. Во фронтальном отделе толщина кости 3-3,5 мм. Пациентка, несмотря на возраст, социально активная. Она не представляет жизнь без зубов. Мы выбрали в этом кейсе использование имплантов Megagen Anyridge. Как вы видите, толщина кости 3-3,5 мм. Мы изменили парадигму. Современная методика использования имплантов – это установка имплантов более палатинально. Разрез тоже ведется, тоже палатинальный разрез. И получаем высокий торг за счет фиксирования апекса имплантов в плотной кортикальной пластинке носовой кости, дно носа. И несмотря на то, что часть витков резьбы палатинально остается открытой, ввиду того, что там отсутствует мышечная ткань на небной поверхности неба, на верхней челюсти с небной стороны отсутствует подвижная слизистая и отсутствуют мышцы, и она сама по себе очень плотная ткань. Поэтому никаких проблем не возникает, даже если у нас витки остаются открытыми. У данной пациентки мы фиксировали на первом этапе 4 импланта фронтально, вверх-вниз. Сразу же изготовили из протеза пациентки зубы, временные зубы. Было проделано двойной синус-лифтинг, открытый синус-лифтинг с использованием справа аутокости. Как вы видите, на этом этапе фронтальные импланты с небной стороны, половина импланта практически открытой резьбой, но при этом никаких воспалительных процессов не наблюдается. И для поддержки мягких тканей была использована в вестибулярном участке контурная пластика. Мы при этом как бы добиваемся контурной пластикой, добиваемся эстетического результата. На втором этапе, вот как вы видите, временные зубы изготовлены из протеза пациентки. На втором этапе, после интеграции наших костей в синус-лифтингах, использован хирургический шаблон и дополнительно поставлены 4 импланта, 2 справа, 2 слева. Вот результат. Через 3 месяца из-за того, что мы использовали аутокость в синусе, смешанной с ксенокостью, мы смогли через 3 месяца изготовить второй комплект временных зубов. И при этом пациентка использовала временные зубы снизу и наверху. И по происшествии еще 4 месяцев, ввиду использования материала PMA, мы добились образования треков движения. Как известно, самым хорошим артикулятором является сама ротовая полость человека. За 4 месяца использования временных зубов пациентка стерла определенные части зубов, и при этом на втором этапе мы сканировали эти временные зубы, верхние и нижние, и были изготовлены постоянные зубы, 12 наверх, 12 вниз, с титановой балкой из композитных зубов. Это легкая и прочная конструкция. Как вы видите, мягкие ткани пациентки, ввиду отдавливания временными зубами, мы получили вокруг имплантов кератинизированную, неподвижную мягкие ткани. Вот результат несъемной конструкции, 12 наверху, 12 внизу, легкая конструкция, композитный материал и усиленная титановой балкой. Весь этот процесс занял 18 месяцев. Это в этом клиническом случае не представлялось возможным изготовление, не представляло возможность имплантации угловых имплантов, потому что практически нулевая кость под синусами. Мы пошли путем аугментации. Но для сравнивания хочу вам представить второй клинический случай. Тоже использование имплантов Megagen Anyridge. Это снимок этого же кейса. Как вы видите, 8 имплантов, 4 импланта находятся в синусе, 4 во фронтальном отделе. Никакой атрофии не наблюдается. Эстетичный результат. А сейчас я хочу представить вам второй клинический случай. Женщина 38 лет, молодая, у нее тоже атрофия костей. Мы в этом кейсе пошли путем использования техники V2V. Это установка 4 имплантов во фронтальном отделе, 2 вертикальных, 2 под углом и 2 импланта птеригоидных имплантов. В этом случае тоже использовали только импланты Megagen Anyridge, которые дают нам прекрасную стабильность. Вот представляю вам случай. Тоже, значит, во фронтальном отделе, как видите, все 4 импланта были фиксированы плотной кортикальной пластинку, дно полости носа. Фронтально-вестибулярно тоже использована аугментация для контурной пластики, для поддержки мягких тканей. Megagen Anyridge, торг свыше 50 ньютонов. И были использованы импланты длиной 15 мм в области птеригоидной зоны. Как вы знаете, импланты фиксируются медиальной пластинкой птеригоидного отростка, где очень плотная кость, и мы получаем тоже высокий торг. Как вы видите, под общей седацией торг 50 ньютонов. Вот все импланты были погружены, фиксированы в плотную кортикальную пластинку. Техника V2V. При этом Мы тоже добились стабильного результата мягких тканей. Как вы видите, временные конструкции отдавлены мягкие ткани были отдавлены временными конструкциями. Это конечный результат. Спустя всего 3 месяца. Значит, в зависимости от клинической ситуации мы используем либо аугментацию с последующей имплантацией, либо сразу имплантируем без аугментации с использованием угловых имплантантов. Ввиду дизайна имплантов Megagen Anyridge мы получаем высокий торг за счет его апекса. Как известно, при использовании в области дна полости носа или в области птеригоидного отростка мы используем остеотомы, диаметр которых составляет 2 мм, минимальный диаметр. И при этом импланты диаметром 4-4,5 мм дают нам очень высокий торг, апекс которого резьба начинается от 3,5 мм и дает нам эти 3,5 мм после использования остеотома 2 мм, дает нам очень высокий торг. И мы можем непосредственно производить нагрузку. И если позволяет нам клиническая ситуация, мы стараемся не использовать аугментацию в последнее время, а широко используем импланты Megagen Anyridge для реабилитации пациентов птеригоидными и имплантами в области дна полости носа. Импланты фиксируются контрфорс, это клыковый контрфорс. Если надо, мы используем назолифт, или идем путем использования хирургического шаблона. Сегодняшняя тенденция требует непосредственной нагрузки, и последние годы практически в любой клинической ситуации при использовании этих имплантов Megagen Anyridge мы получаем прекрасные результаты. Спасибо большое за внимание. Всего вам доброго.
Recording stopped.
Thank you for your presentation.
Welcome.
So
Welcome.
Okay, so the judges, any comments?
It's clear. Thank you, Dr. Huseynov. Good luck.
Thank you. Спасибо. Thank you. Thank you.
Yeah. Huseynov, in the first case, you showed the provisional. You mentioned that's a provisional. You have clearly a metal bar, right, on it. So what was the patient using before that metal bar was fabricated?
Yes, metal bar. First, на первом этапе мы усилили акриловую конструкцию в первом кейсе. На первом этапе мы усилили металлической пластинкой, металл-бар использовали. А на втором комплекте были использованы PMA с тибейсами на втором комплекте. И ввиду того, что PMA он стирается, за 4 месяца мы получили треки движения, которые позволили нам изготовить постоянную конструкцию с меньшим риском для сустава и меньшим риском поломок, для меньшим риском височно-нижнечелюстного сустава. Как известно, самым лучшим артикулятором является сама ротовая полость человека.
Okay, and the last question. For your second case, when you placed the pterygoid, what was the length of those implants?
Pterygoid bölgede İmplant birleştirmesinden mi?
Да, мы использовали в области птеригоидного импланта импланты Megagen Anyridge диаметром 4 мм, длиной 15, диаметр 4 мм, длиной 15 мм. Потому что, как известно, ширина медиального отростка, птеригоидного отростка, она бывает около 5-6 мм. Максимум диаметр, который мы можем использовать, это в большинстве случаев 4 мм, не больше, потому что мы можем разрушить этот медиальный отросток и потерять торг. А после того, как если мы разрушим птеригоидный медиальный отросток, второго у нас шанса не будет. Максимальный диаметр это 4 мм в области медиального отростка, птеригоидного отростка.
Thank you very much.
Welcome.
Dr. Huseynov, if I may, just to further go on with the comment on that. Related to your second case, what was your main indication for choosing pterygoid implants?
Neydi onu seçmişsiniz?
Да, наш выбор в сторону птеригоидного импланта исходил из того, что пациентка была молодая, и нам нужна была непосредственная нагрузка. Ну, как известно, использование аугментации влечет за собой определенное осложнение. Это кость, которая называется криптокостью. Она никогда практически не превращается в собственную кость организма. Мы реабилитировали пациентку всего за 3 месяца. Но если мы использовали открытый синус-лифтинг, минимум реабилитация у нас заняла бы 8 месяцев. Это установка импланта вместе с аугментацией, выжидание 6 месяцев. И этот срок реабилитации увеличился. А так у нас из-за того, что мы не использовали графт, у нас срок реабилитации занял 3 месяца, это хирургический этап, и примерно 20-25 дней ортопедический. Максимум все это заняло 4 месяца.
Okay, thank you.
Welcome.
My name is Emilio Arguello. I am a periodontist. I'm originally from Mexico City. I finished my residency at Tufts University. I spent about 10 years of my life doing research, intense research, so I spent a lot of time studying that bacteria. And when I finished my program, I got invited to become part of the faculty at Harvard University. Now it's almost 20 years since I've been teaching there. In the early stages of my career, I joined the corporate industry, which is one of the largest DSOs in the United States today. Soon after that, I moved to Denver, Colorado, and that's where I practice today. And I joined a private practice. My time had been divided ever since between the corporate world, the academic world, and the private practice world.
Welcome to the Megamind 2026, Season 4, The Road to Toronto.
Megamind is a very good project, and I'm honored to be invited as part of that team because that gives the clinicians, especially the younger clinicians, the ability to foster an unbiased approach and knowledge, and not to become necessarily attached to a product or a system. And also another thing that I praise a lot for the project of Megamind is that they have paid a special attention to the people that judge are not necessarily affiliated 100% to a company and freely judge the cases that are coming through without that attachment to the industry. What am I looking for in that competitive environment? The most important thing is how were you able to serve your patient in the best possible way? Your train of thought help that person's life and improve that person's life. It's also important to think outside the box. If you are able to deliver the correct treatment to your patient, along with an environment that you were able to come around the problem by the open-mindedness of thinking of a potential solution, that makes the case even more interesting.
I am Professor Pramchai Chansityanon. I am the Dean of the Faculty of Dentistry, Chulalongkorn University, Bangkok, Thailand. My specialty is oral and maxillofacial surgery, and my passion is education, research, and inspiring the next generation of dental leaders. To me, Megamine is not just a competition. It is a place where ideas grow and innovation thrives. I join because I believe in supporting young professionals who dare to think beyond the usual. When I was a student, we didn't have something like Megamine. Global platforms were rare, and opportunities to share ideas internationally were limited. That's why I value this so much. It offers the kind of chance I wish I had. For the next generation, Megamine is a gateway to connect with peers, to learn from mentors, and to share their vision with the world. It is a chance to grow, share, and truly make an impact. The real strength of Megamine is that it combines competition with collaboration. It's not about the winning. It is about learning, sharing, and building a community of innovators. I am looking for finalists who show skill, creativity, and a sense of responsibility. Ideas that are not only innovative, but also have the power to help people in real life. Believe in your ideas, stay curious, be bold, and remember the ultimate goal is to make a real difference in patient care and in our profession. Unlock your potential, test your mind, Megamine.
It's okay. Do you like it?
My name is Dr. Beatrice Lang. I'm a practicing prosthodontist.
All right, so Maureen, how's the gum on the, it's healed up, right?
I've been in private practice since 2005. My journey starts with going to dental school here at the University of Toronto. When I graduated, I realized that I was not comfortable practicing yet. So I moved to the States and I did a year of hospital residency at Boston Medical. The 3 years when I was in prosthodontics studying, that's when I realized that what I learned in dental school was not adequate. It was just a lot, there were a lot of missing links. I've always wanted to be able to help people to connect those missing links that were always there. So I got the position to teach back at the same dental school that I went to. So now I've been teaching for the last 6-7 years.
Megamine is a global stage for aspiring dentists to compete for a chance to become the next generation of leaders in implant education.
Megamine Global Competition as an opportunity to improve on my public speaking skills. There was no age limit. At this point in my career, why am I doing it, right? Yeah, to me, it's every opportunity is an opportunity to learn from, whether it's good or bad. Why not just try it? What's the worst that can happen? You don't win. You walk out with new experiences, meeting new people, and I think there's always something good that will come out of this experience. part of me is showing my sons that I'm still learning. I'm not perfect. I'm not afraid to try new things, and that I might lose, and that's fine. I like to do what I tell them to do.
Surgery is the best because I couldn't even imagine doing me endo, prosto, ortho every day because surgery is who I am.
So I went down to the water and found my faith because I don't want to be stuck in.
So hello, my name is Evelina Ginevičiūtė and I'm from Vilnius, Lithuania. Now, why I become a dentist? It's like a funny joke, but when I was 3 months old, so my mother had a lot of dental visits, and after one, as she said, painful and, as she said, very expensive appointment, she looked at me, at the baby, and said, "You will be a dentist." And from that moment, it's natural. Evelina is a dentist, and now I'm a dentist. So honestly, I'm happy, and I'm grateful for my mother because I love what I'm doing. And what I'm doing if I'm not working, so I love food very much, and also I love traveling, exploring new places, and I'm combining it with active activities because my biggest love is water, and I love surfing, wakeboarding, diving, and etc. My personal goal and my professional goal, I still believe that I can manage and I can be a top expert and still live and enjoy life. I think that Megamind is not just a competition. Yes, it's a competition and the winning is not a goal. I think that the most important thing that we are together and we are sharing ideas and creating that big, strong community. So how I'm feeling? I'm happy. I think I'm happy.
Oh no, you ain't seen nothing yet.
Hi, I'm Dr. Mustafa Jamil. I'm a periodontist. I born in Egypt and I spent my whole life in Cairo, Egypt. My private practice, I have 3 clinics and I'm starting all my way working in Egypt. I started my Faculty of Dentistry studying in 2005 and I finished my PDS on 2010. And I started in 2012 after finishing my residency, going with a master degree program, working with my master degree thesis on the sinus lift, trying to dig into the field of sinus lifting, how to do the sinus lift, the open and closed approach. Starting my day early morning at 6 a.m. to have a chance to meet my kids before going to school and taking them to the bus where they go to the school. Then starting my day with a fresh shower and go to mosque to have my prayer, and then I read part of the Quran. Then I take my car and go to the gym. In the gym, as you know, our profession is very, very tough with a lot of stress, so we need to relieve this stress with the gym. After the gym, we have to go to the pool to relieve with the cold. Then I'm ready and fresh to start my clinical day and see my patients. While I'm in the car, I'm starting talking to my receptionist and check do the patients are ready or not. to talk with my team to prepare everything for our day. As you know, the dentist is like a family member. We are trying to build a good relationship with our patients. It's not about money, it's all about reputation, about delivering the best for your patient. Especially when we are talking about implantology, it's not a hit and run. Most of our cases may take 1 or 2 years to finish, from augmentation, soft tissue and hard tissue, temporization, scans. It's a lot of work. So if you don't have the ideal relationship, a clear relationship between you and your patient, you will suffer a lot and the stress will be much more. After that, it's very important to communicate with your team members. To improve the quality, it's not about you, it's about how you're gonna deliver, what your goals as an institution, what the goal of this, how to prepare our patients, how to prepare our schedule, how to make everything comfortable the best way for our patient. Apart from the clinical work, I'm dedicating a very large part from my life for education. We are working with the Advanced Implant Program. We have a lot of young dentists who are aiming to learn implantology from basic to advanced. Regarding Megamind, from where did I know about Megamind? For me, it's a brilliant idea. So you are connecting young implantologists to share their own cases together. It's not only about selling implants, it's about improving the quality of not only dentists but also speakers. So Megamind, they are creating a future speakers. So the idea was brilliant. Why did I apply for Megamind? I found that it's a great opportunity to network with doctors from all over the world, to have a better exposure for new techniques and new doctors, how they are delivering and how they are treating their patient, to learn from each other and sharing knowledge together. Regarding Megamind 2026 taking place in Toronto, Canada, for me, I never visit Canada, so it's a good reason to attend there. But also it's a very prestigious event to share among all these world-class speakers. I would love to share them, and I would, of course, I'm looking forward to be the winner. It's not easy, of course, but I will do my best.
I think that dental implantology should not be a traumatic experience. Should be the opposite. Should be more human, more close and comfortable.
Thank you. My name is Dr. Hikmat Bakhishov. I am oral surgeon and a periodontist with a PhD, and it is a great honor to be presenting today at the Megamind Continental round. Before I begin, I would like to sincerely wish the best luck to all the participants. It is a truly inspiring to share the stage with such a talent colleagues. And today I will present clinical and challenge and the case. This highlights a biological oriented and prosthetically guided approach to restoring function and occlusal harmony. Throughout the presentation, we can watch our presentation. You will notice QR codes linking to the key scientific publication. We kindly encourage the scan this QR code to explore evidence supporting the clinical decision presented. Our key cases and the hero is a 47 years old female patient. Our patient presented with functional aesthetic compliance. She was systemically healthy and diagnosed with a stage 3 and a grade B periodontitis, accompanied by compromised oral hygiene and severely accentuated of the curve of speed. The patient declined orthodontic treatments and requested a fixed implant-supported rehabilitation. Clinical and radiographic evaluation revealed multiple missing teeth, 17, 15, 21, 24, 25, and etc. The patient was wearing long span porcelain fused to metal dental prosthesis, including maxillar bridge extending from 11 to 27, and the mandibular bridge from the 43 and the 48, contributing to occlusal instability and the further exaggeration of the curve of the spine. Viewed in the sagittal plane, occlusal curvature is a naturally occurring phenomenon in the human dentition, termed after the curve of the spine, firstly, and described by from Ferdinand von Graf's spine at the 19th century. Spine line connected to the anterior surface of the mandibular condyles to the occlusal surface of the mandibular teeth, of the arch of the circle tangent to the surface of the cylinder line, perpendicular to the sagittal plane, Curve of the spine is very important for the planning, orthodontics, and the prosthetics, and the treatment in the field in the dentistry. CBCT evaluation of the left posterior maxilla demonstrated insufficient vertical and horizontal bone volume, resulting from the sinus pneumatization and the ridge deficiency and the long span and addentia this region, making implant placement unfeasible without bone augmentation. Assessment revealed maxillar sinus was classified A, narrow taper, according to the Lichuan New Classification 2018 research paper. Prior to surgical intervention, comprehensive non-surgical periodontal therapy was performed, including subgingival instrumentation and the oral hygiene instruction based on the EFP protocols. Following periodontal stabilization and improved patient compliance, the treatment proceeded to the surgical phase. The existing porcelain-fused metal restoration were removed, and all surgical procedure carried out under the conscious sedation. Lateral window sinus augmentation has been performed with a piezosurgery. Sinus augmentation combined with horizontal ridge augmentation was therefore performed using xenogenic bone graft material, collagen membrane, tenting pins, and the membrane fixation pins to ensure the graft stability, membrane stability, and the space maintenance. Maxillar sinus elevation is a common surgical procedure to increase the bone volume in the atrophic posterior maxilla, prior to dental implant placement. It can be achieved a lateral approach with a simultaneously or delayed implant insertion. The lateral sinus lift procedure is indicated in case of the severe bone resorption, not allowing standard or the implant placement, not implant insertion in the combination with a crystal approach. A novel technique known as the tentpole grafting has been described, in which block grafting and the curate technique is fixed over the edentolos ridge with a distance, and the underlying gap remains either unfilled or it is filled with a mixture of particulate, bovine, and the xenogenic autogenous bone graft materials. The tenting technique originated from the principles of the GBR, guide bone regeneration principles, and the philosophy, and it involves raising to the periosteum like to the tent to allow osteoblasts to migrate into the gap to start osteogenesis. The gap remains unfilled, or it can be filled under osteoinductive, osteoconductive materials in some cases. Simultaneously, tissue-level implants were placed in the posterior mandible side, 46, 44, 36, 34, and the left mandibular wisdom teeth extracted to poor prognosis, and the extraction site has been grafted. After 6 months healing period, during which a patient was provided with maxillary provisional restoration, follow-up CBCT imaging revealed substantial improvement in the ridge dimension, confirming adequate bone volume for predictable implant placement. Subsequently, additional bone level implants were placed at the site 24 and the 25 region, and the provisional restoration were adjusted accordingly to the patient. Following a further 3 months post-integrated period, PMMA provisional restoration were delivered in the both arch on teeth and the implants, with the exception of the natural teeth of the patients, 42, 41, 31, 32, and the 33. This enabled us to evaluate occlusion, aesthetics, functional comfort, and the shape selection. This phase allowed us to evaluate function, comfort, refinement of the occlusal scan, and served as reference for the morphology and definitive restoration. And patient feedback was incorporated prior to final prosthesis fabrication. After successful evaluation of the function, aesthetics, and occlusal stability, the final implant-supported prostheses were delivered. We used this case zirconium oxide bridge, zirconium oxide high biocompatibility, a low plaque surface adhesion, absence of the mucosal discoloration, and the aesthetic property contributing to successful soft tissue integration and the patient satisfaction. Non-hygienic inaccessible restoration are significantly associated with implant loss, and the high rate of the implantitis has been proved in the research paper. The treatment resulted in the significant improvement of the curve of the SPE, restoration of occlusal harmony, and the enhanced function and aesthetics. In conclusion, 𝐶𝐑 manufactured screw-retained full-arch zirconium oxide implant restoration are viable alternative to the porcelain-fused metal restorative options for rehabilitating of the edentulous and the patient vis and the adentia on the region and the patients. At the 2 years post-delivery follow-up, clinical and the radiographic examination demonstrated stable peri-implant tissues, satisfactory prosthetic performance, and a marked improvement in the oral hygiene, indicating a favorable long-term outcome. Thank you very much for your kind attention. This case reflects the importance and the basic decision-making combined experience and the long-term follow-up. I truly appreciate your time, and I will be happy to answer your questions. I am grateful for this vitrine. I wish all the best of the Megamind team. Thank you.
Recording stopped.
Thank you for your presentation.
Thank you.
So, the judges, any comments?
I can start, if I may. Prof. Kelvin, okay. So thank you, Dr. Bakhishov. Do I spell it correct?
Thank you.
So for the sinus, so for the vertical deficiency, things are clear. You went for the two-stage approach with the sinus lifting. Tell me, please, related to how did you manage the horizontal deficiency? It was sausage technique or?
Actually, thank you for the questions. Actually, dear professor, I manage this and the case because and the patients there is not some harvesting and the query and some autogenous bone block actually, and I prefer autogenous bone plate maybe and some marrow, and that our patients because it is very all the surgical procedure and carry out conscious sedation, and the patient, there is not some harvested, some autogenous and the bone. For this situation, we decided to manage only and tent pole technique. We used here only and the tenting pole screws. After field and the little and the bone we get harvested and with a bone scraper and the autogenous bone chips, and after we mix particulated, and we actually I saw that we only manage and the very and the high elevation of the periosteum only, because there is not some tension and the flap, and the patient pay attention for some procedure and the post-op situation, and actually we place it in the implant. Normally adequate bone volume we get with done.
Thank you so much. Thank you.
Thank you, dear professor.
Okay, Hikmat, just a quick question. What was the occlusion? What was the occlusal configuration that you decided for this particular case?
Actually, you know that I am oral surgeon, and our prosthodontics, and you know that to help to restoring our this case. We firstly, actually, because in the time it's short, I didn't explain all the details. And beforely, we delivered and took patients and the PMMA restoration for a long time. And after we, you know that we managed some condos, some occlusal forces, and because the patients and firstly you know that and the start of the time of the rehabilitation, and the patients we feel a very high pain for the candles, and before we try to normalize on the occlusal. After we fix some teeth and normal and the patient feel and some occlusal. After we step by step we try to a normal bridge. So
perfect. Thank you.
Thank you.
I will start. First of all, I would like to thank Megagen company and MINEC team for opportunity to participate in Megamind 2026 in Continental round. It's the first time for us with our clinical case. My name is Anton Dabrytski. I am a prosthodontist from Belarus, and together with my colleague Vladimir Shelek, implantologist, we are co-founders of Shadow Clinic in Minsk, and we together solve rather difficult clinical cases with total implant rehabilitation. Total implant-supported rehabilitation, an entire logical trend has emerged in recent years from our points of view, and this trend is to achieve the most aesthetic outcome with the fixed prosthetics on the dental implants with FP1 type. In 1993, Karl Misch presented the classification of prosthodontic constructions, and we are interested in the main two types. FP3 type, it is the bridges with artificial gum, and the most natural looking FP1 type of the bridges. These two types can be similar, or these two types of cases with FP3 and FP1 type, they can be similar in quantity of implants, but very differ from another hand when we speak about the final aesthetic results. When we work with FP3 type of cases, we can use even the freehand implant placing and prepare margin for the whole bridge. And when we speak about FP1 type of constructions, we speak mostly about thoroughly planning, about the navigation surgery, about prosthetics outcomes in the perfect position, about CAD/CAM technology, of course about bone grafting procedure, soft tissue management, and even about the periodontal suturing techniques. But not in all cases we can receive perfect result with FP1 type. And through our clinical case, we would like to demonstrate the perfect condition for achieving FP1 type of the result on implants. We have 61-year-old female with the total rehabilitations on the upper jaw. And with ideal conditions for achieving FP1 type of the bridge on the upper jaw. The first condition is the presence of so-called gummy smile. It is situation where during white smile, not only patient anterior teeth are fully exposed, but also the portion of maxillary alveolar process also exposed. So the first one is the gummy smile. The second one is the absence of significant hard and soft tissue defect in the anterior region, or like in our cases, even better situation when with the patient with preserved tooth or roots in the fronts. The third condition is absence of periodontal diseases and high or big vertical bone defects, because these two signs can make rehabilitation less predictable. The fourth condition is sufficient antagonist teeth, presence of teeth on the opposite jaw, or good quality prosthetic construction like in our case. That's why our first step in total rehabilitation was to rehabilitate a lower jaw with temporary PMMA bridges, implant-supported bridges in the back side, and two supported bridges in the front side of the lower jaw. And the fifth condition, the last but not least, it is sufficient bone volume for implant placement with proper prosthetic emergence. Every next year, with advent of new implant products and improving planning software, the minimum required bone volume is steadily decreasing. But even in our cases, in the backside of the upper jaw, we have only from 5 to 7 millimeters of bone height, and is a critical minimum for implantation. When we speak about FP1 type of rehabilitation, we speak about digital procedures, about digital planning, and we should clearly understand that that in every case we need at least 3 fixed points on the jaw. Through it, we will compare all our scans in one project. I mean, pre-operative scan, post-operative scan, CBCT, and so on, and digital WhatsApp. All this information we can compare in one project if we have only 3 fixed points on the jaw. And in our case, we think that these 3 points can be 2 canines and the first molar on the right side of the upper jaw. In the software, after the first scanning, we removed all virtually removed all teeth except canines and the first molar, and made digital WhatsApp. According to this digital WhatsApp, we can now start to place our implants. We start our work, our planning of placing implants from the front side of the upper jaw in the position of central incisors. A lot of articles shows us that smooth palatal position of the implants allows us to live more at the gingiva vestibulary and gives us opportunity to have direct prosthetic components that are preferable in the aesthetic total implant-supported rehabilitations. And we should place implants submerged to attached margin line at least on 4 or 5 millimeters, according to the ZBLC concept of the Professor Thomas Lenkiewicz. In the same manner, we place implants in the premolar zone, mostly with the smooth palatal position and submerged. And then we planned to use short and wide Anyridge implants in the backside in the zones of in the molar zones as alternative to the sinus lifting procedure. But spoiler, things don't always go according to our plan, and the use of surgical guides itself do not guarantee success in 100% of cases. And in our case, we didn't achieve sufficient torque in the left molar region and had to place pterygoid implant freehead. But using short and wide implants in the molar zone can give us predictable distal support, and it gives us opportunity to use direct or 0-degree prosthetic component that are mostly preferable in cases with a highly aesthetic FP1 type of construction. The next step, planning additional fixation components and drawing the surgical guide. Now all is ready for navigation surgery, and after anesthesia we gently removed all teeth except canines and the first molar, and collected connective tissue transplants from the tuberal region of the upper jaw, placed surgical guide, and placed the implants submerged due to the ZBLC concepts of Professor Thomas Lenkiewicz, with, and it is very important in such cases, with additional bone profiling in the front zone. The final step of surgical procedure, it is grafting. It means preservations of post-extraction sockets with xenograft materials, and soft tissue grafting near all front teeth and defects of the upper jaw. After the surgical part, in the same day, we made the scanning also before the removing of canines and first molar, because it is the fixed points for matching pre and post-operative scans and wax up. Then we transform our digital wax up to the modeling of the temporary healing PMMA bridge. During modeling of the temporary crowns, we should keep in our mind rules of EBC concept that helps us to understand rules of healing procedure and guide the healing process. So we milled in our laboratory, we milled PMMA bridge directly from the level of multi-unit abutments without any T-base, and fixed it the next day after the surgical part. And on these photos, you can see the pre-operation situation, the day of fixation of our PMMA bridge, and 2 weeks after the surgical procedure and final suturing. Here also this situation after 2 weeks. This is our control CBCT scans before surgical procedure, after surgical procedure, and 1.5 years after the final restoration. In 12 months, we are eager to finalize treatment with the final construction. For this purpose, we used a fully digital protocol with the photogrammetry, with the shining elite scan, and it gives us opportunity to receive highly precision information about multi-unit position in the mouse. For the final treatment, we choose a zirconium bridge reinforced with the titanium bar as a final construction. Now you can see the situation after the final after the fixation of zirconium bridges. We think that this type of bridges, I mean the zirconium with titanium bar, it is one of the most predictable long-term type of implant-supported construction with the perfect natural-looking design. And you can compare the situation before and after the final treatment. In conclusion, I would like to say that the many unique Megagen products and huge desire to be the part of MINEC family and Megagen family gives us strength to use such methods to receive such great result, even in the difficult cases like in our patient. So thanks a lot for your attention and for your time. I finished.
Recording stopped.
If you have any questions, I can answer them.
Thank you for your presentation. The judges, any comments?
Okay.
Professor Kelvin, after you this time.
So it's clear to me that you're an excellent prosthodontist. You can control FP1 for maxilla, which is not very easy, right? And you need to be very patient to model the soft tissue contours. I wanted to ask you, how many sets of provisionals did you have in this case? Was it only one or?
Only one.
Only one. Okay.
Only
How did you manage so you wouldn't get fracture?
You mean fracture or your fracture of my provisional?
Yeah.
It was the reason why we started the final restoration not in 18 months but in 12 months. The patient told that he have any
problem with this restoration. That's why we started the final restoration. I think I don't know even why it was broke, because on the control CBCT and panoramic scans everything was okay.
Perfect.
It's rather simple case. That's why we didn't use multiply surgical guides, and because it was the perfect situation for FP1, and that's why I demonstrate this case, but because it is the perfect situation for FP1 and very simple situation.
So you get a lot of advantage from having a cross-arch stabilization by having it as a single unit prosthesis. Do you see any advantage if it would be section in the middle? It would be two pieces.
No, I don't think that in other cases we use mostly 8 implants on the jaw when the patient is very young, for example, 30, 35, 40, 45 years. We mostly use 8 implants in the position of central incisor, canines, the first premolar and the second molar, and we divide this construction into the 4 bridges. But when we work with patients after 65 years, when they are old, we mostly use the mono construction with mostly 6 or 4 implants on the jaw.
Perfect. And my last question, just picking on your brains, what type of occlusal configuration did you use in this case?
I think that it was the lingual type of prosthetics or of occlusal configurations with the it's not the occlusal configuration of the normal patient. I mean the fully reconstruction of occlusion, but it's a lingual, only the small points on the lingual parts of the occlusion surface.
Okay. Thank you.
Thanks a lot.
Thank you as well, Dr. Dabrytski. And from my side, I have 2 questions. The first one would be, what guides your choice between a multi-unit abutment and a NAXA abutment? I have seen that you mentioned both of them in practice. And to move things a little bit forward, do you also prefer sometimes to use a multi-unit abutment? Not a multi-unit, sorry, an auto-bridge concept, sorry.
You mean, can you concretize, you mean why we use multi-unit abutments in those reconstructions, and why we don't use simple from the level of the implant construction?
Well, first of all, I'm not criticizing, I'm appreciating, but I was asking, what guides your choice between using a multi-unit abutment and an NAXA abutment? Because you mentioned that you use both of them in your practice.
Yeah, I understand.
And secondly, do you sometimes prefer using an auto-bridge concept? I don't know if that is...
I don't understand, what does it mean, auto-bridge?
Auto-bridge is the... auto-bridge is from Rhine. So it's an option to multi-unit abutment. If that it's familiar to your practice, that's it. It's just an extension of my first question.
So mostly in our practice we use Anyridge implants. It is nearly 70% of implants that we use in total rehabilitation, because Anyridge implants, it is the most suitable product for the direct implant-supported rehabilitation, and that's why multi-units it is the most using products in our practice. But in some cases we have difficult cases with large bone defects or very thin alveolar ridge, and we use we use implants with the long neck, and then we use or blue diamonds implants when we have very thin alveolar ridge on the lower jaw. And in these cases, we use AXA abutments on these implants, of course.
Okay, thank you. And the second question would be, how do you practically assess the most, let's say, convenient occlusion for this large rehabilitation?
You know, I don't know the perfect situation, but mostly we use, as I said, lingual scheme of the occlusion with a small dots of on the lingual parts of occlusion surface on the upper jaw, on the upper teeth.
It's clear. Thank you so much.
Thank you.
Hello, my friends. My name is Dr. Idrissova. I'm from Estonia, and today's topic is rebuilding confidence after tooth loss. So guys, if I'm asking you a philosophical question, how do you define your success? Is success the same as happiness, or success is a special achievement, a special moment, implant survival, absence of mistakes, perfect x-rays, or just simply doing things right? What if I tell you that even if I do things right, I can still have a complication? So let's just jump straight into my real life scenario and we will see what happened. This is my female patient. She's 75 years old and she wears removable dentures in her upper and in her lower jaw. Actually, she is very satisfied with her lower denture, but she doesn't like her upper denture at all because the upper denture covers her palate and she doesn't feel any food taste. That's why she's searching for some kind of implant solution, fixed implant bridge or fixed denture, which is supported by the implants. So our first appointment was on the 15th of July, 2021. And actually this photo here shows you that once the first appointment has been already, then the time starts running and it cannot be frozen. It means that every appointment counts and the patient is waiting anxiously for the final prosthesis to be delivered. That's why our responsibility is just to find the best possible solution in this case. These are the intraoral photos here, and Oh, sorry, just putting. Do you still see my screen? You see, okay. These are the intraoral photos here, and you see upper jaw and lower jaw. And in our upper jaw, we see 4 teeth. Actually, this is a long span bridge here in the second quadrant, and 3 abutment teeth, which are holding this bridge. And also her upper denture, which she doesn't like at all. Second, still some kind of doesn't react. Okay, no, it's okay. Side views, and we see her upper teeth and lower teeth, and also the status of gingiva, which at the moment is not healthy at all. So we have to take this into consideration. These are the photos with her removable denture in place. She's totally satisfied with it and doesn't want to do anything. But actually, we have to persuade her just at least to renew the denture. So the occlusal contacts between our future denture, upper denture, and the lower denture will be all right. Yes, because we see that the teeth here are worn out. The panoramic X-ray of the lady, 4 upper teeth, and we see that root caries, subgingival calculus, and also periodontal space is enlarged. So there is just stage 2 and 3 mobility of these teeth. So our option was to plan all-on-4 concept, just to remove all 4 teeth and to put 4 implants instead. Yes, and this is just for you to see and to compare her X-ray 9 years ago. And you can see how the clinical situation can change in one patient's mouth just in a couple of years. Here we see fixed bridges, and I may say that's a lot of teeth here in the mouth, but still now we're just making her edentulous in maxilla. And of course, all-on-4 concept, it's a good idea, but you all agree that your own tooth is the best option in the mouth. Before presenting her treatment plan, I have read literature about the success rate of fixed implant-supported dentures in the elderly population. And I have found that the long-term survival rate is very high in the elderly population. It means that it was 98% in 10 years and 99% survival rate in 5 years. So actually, it's a good idea, yes, to make this all-on-4, all-on-6, or whatever, even if a patient is 80 years old and so on. So our treatment plan was to extract all 4 teeth in her maxilla, then to make a removable denture, just so she wouldn't walk around without teeth, and then afterwards to put implants. Of course, you can ask why there is no immediate implants in this case. The patient insisted on so-called old school approach. She didn't want any immediacy, so she decided she wanted to extract the teeth, then to wait 2 months, well, 2-3 months, then to put implants, to wait, and then only to put to make her prosthesis. She was afraid of the surgery, of different procedures. She has just talked to her relatives, and that was her desire. Well, okay. Actually, I have told her about the possibility to extract the teeth and to put implants immediately and to make also a temporary denture at the same day, but she denied it. So, okay, that was her desire. Other treatment options. Of course, we could think about overdentures, bars, locators, sync-on concept, even magnet attachments. But the patient told us that she was interested in something which was fixed. We have talked about the implant-supported bridges, but in this case, we will need more implants, we will need more money. And as the treatment plan became more expensive with this implant-supported bridges, the patient told us, okay, I'm fine with this all-on-4 solution, let it be like this. So we made a full thickness flap. We used bone-supported surgical guide and Autogenous software to just perform our surgery. So just in 4 pictures, all my case here, you can see that we removed 4 teeth in her upper jaw. Afterwards, she was wearing a full denture just to socialize with people and to maintain her function, eating. Then we put 4 implants, and this is ready denture, upper denture. Once more to remind you, of course, nowadays we all know about immediate implant placement, and that's a great idea if the soft tissue and bone allows us to do this. But sometimes still we have to wait until soft tissue heals or until soft tissue and partially bone heals. Or why not? This is type 4, when we wait until soft tissue and bone are totally healed and we just put this implant in a predictable place. Actually, the surgery in this type of implant placement is easier compared to immediate implant placement. So what about our patient? We put her 4 implants. This is ankylous implants, A8, which means A is 3.5 millimeters diameter and 8 means 8 millimeters in length. After the procedure, the patient felt weak and fainted. Then she started vomiting and we had to call emergency. It means that I couldn't take any post-operative X-ray and I was hoping the best that everything will be all right. Yes, but the time went on and everything was good. So the patient returned to us and we started with our prosthetical part. You see here that this is not digital approach. It's a conventional analog, so-called old school approach. And we made this 5 or 6 try-ins because the patient didn't like the size, the inclination of her teeth, but at least she was happy. And she told us, okay, this kind of teeth are the one I like. Panoramic X-ray, you see here 4 implants, titanium framework just to give the rigidity to the denture. Delivery of implant-supported denture and the smile of a patient. And of course, we all as clinicians know that the main risk here is hygiene. I mean, inadequate hygiene, yes, and peri-implantitis, because if mucositis is reversible, unfortunately, peri-implantitis is irreversible condition, and we have to be very, very attentive in this place. So interdental brushes, superfloss, water floss, or whatever, yes, they have to use just to maintain clean area around the implants. And I have removed this denture several times to make a big distance between the gum, the soft tissue, and the denture base, so this old lady could use her interdental brushes easily. And this is the photo here. You can see improved self-esteem. This is the patient before and the patient after, and she was really happy, she was satisfied, and everything was perfect. Once more, this is 2024, and here we can see 4 implants, everything seems to be stable, titanium frame. Okay, the patient is happy, I'm happy, and everything is all right. And at this very moment, I want to say, okay, and they lived happily ever after. But this is reality. I'm turning the page of this book, and what we can see here, we can see that during checkup appointment, there was a sinus tract in the region of implant 23. What did we do? Actually, we did everything. I mean, we removed the denture, we polished the denture, made incision, debridement, irrigation with metronidazole solution, airflow with erythritol powder, and biolaser diode laser treatment. Like, we did everything we could at this situation. And after 1 month, when she came for a checkup, there was no sinus tract and everything seemed to be stable. There was one more appointment, and of course, patient used oxygen mouthwash. She used oxygen gel. We made periodontal probing, and there was no pockets more than 5 millimeters, deeper than 5 millimeters. But on periapical X-rays, we saw bone loss. We saw bone loss around 1.3 and 2.3 as well. And actually, to be very honest, if we look at other implants, then there is something going on there as well. We also repeated our treatment. And these are the photos just 2 months after. And I really want to hope that the situation here is better in 2 months. just compared to the first X-ray, which was done on the 18th of February 2025. The patient, every time she comes to my office, she says that she's happy. She doesn't even understand why she has to come for a checkup, because she has no problems. Yes, because she can chew, she can speak with other people, and she's totally satisfied. These are the intraocclusal photos, intraoral photos of her denture. Also, we made her a new lower denture, so the contacts are quite stable at the moment. The photo of 4 implants in her mouth. And of course, every time I took her, I removed her denture, I made photos, and I showed her this, the situation with plaque condition. So there is still a room for improvement for her, because there are some difficult places where she perhaps doesn't clean with intradental brushes so well as in other places. Follow-up in 2025, still everything stable and the patient is happy. And now you can see that 2023 is one type of teeth here, and 2025, the teeth are a bit different. This is because one day she came to our office and said that she didn't like 8 teeth from first premolar to first premolar on the other side. We had to remove these teeth and to put another set of teeth and to incline them more palatally. So this is the final solution, and she's very happy with it. Here you can see a small video when the patient smiles, and you can see how everything changes. So from my perspective, thank you for your time. And you know that not all success is fixed. Actually, some success may come as a removable overdenture. So my point of view is that sometimes if we're speaking about elderly population, it's better to choose overdentures because they are stable, but they are also very easy just to maintain and to clean. The hygiene is simpler there. If you ask what is my plan B in her situation, then I can say that we can also make a conversion of her suprastructure from fixed denture to an overdenture. Yes, and that will be one possibility if I see that the peri-implantitis status wouldn't be stable. Yes. And to me, to myself, success is a journey. It's not an achievement. It's not a special point in my life. It's not a destination. And as you saw that our case had this peri-implantitis status, then I think it would be correct to say that this story is to be continued. So thank you.
Recording stopped.
Thank you for your presentation.
Thank you.
Thank you. So the judges, any comments?
I have some questions. You mentioned that this could be an overdenture in the future. I would like to know what kind of overdenture would be, bar overdenture, or would have some individual stud attachments. What kind of overdenture would be?
In my hands, for example, bars work quite well. So I have experience with bars, and I think that's a good idea. This is number one. Of course, we can speak about locators. That's also one possibility.
Okay.
But the most important that they can clean. And sometimes when we use bars, then older patients even can't clean under the bars efficiently. Perhaps locators would be easier, but with the locators, I'm questioning the stability of the overdenture in maxilla. That's why we have only 4 implants there.
Mm-hmm. I would like to ask you something else. So there was quite of plaque accumulation, right, in the acrylic, in the intaglio surface. Wouldn't it be better if it was metal in that area, or it would have been all, probably zirconia? Was that or has to do with the budget?
Yes, unfortunately, she couldn't afford her zirconia because it is much more expensive solution. But that's Good point. Yes, thank you. But you mentioned also that the metal framework, which will touch gingiva, I think that would be better because my other works I have done with this metal, just which was touching gingiva, and the plaque accumulation was just lesser. It wasn't as big as in this case.
Perfect. You mentioned that you were not able to take some X-rays at some point because of she was vomiting, right? What kind of medication we can provide to the patients so we can avoid, that sensation during surgery?
Can you please repeat your question?
Yeah. So patient was vomiting, right? So you couldn't take some X-rays afterwards, right?
Yes.
Because yeah. So in order to be able to take X-rays, or in order to avoid patient from vomiting, if we know that patient might suffer from gagging reflex or some sort of situation that could get in the way with the surgery, which happens, what kind of medication could you give to prevent that from happening?
Well, the main reason why she was vomiting was not because of the gag reflex, but she in total felt very weak and she couldn't even stand. I mean, that was not the problem with the putting sensor, because we wanted to make a panoramic X-ray, but she couldn't even stand. We had to hold her, and we were very worried about her general condition. That's why we called emergency.
Understood. Okay, the medication is Zofran.
Yes. Okay. Thank you. Thank you for your questions.
Presentation. If I may, I would like to ask you just one question. In your experience, what are the most common biological and mechanical complications associated with implant-supported overdentures?
I think it is the risk of inflammation and peri-implantitis if we're speaking about older patients.
In comparison to a fixed rehabilitation. So let's make it a little bit more clear. So this would be the biological complication, okay? What about the mechanical complications?
The mechanical complications, of course, the fracture of denture base, if we're speaking about acrylic denture, fractures, and I'm just thinking about my experience in this field. I think that the first place will be the fracture inside the denture. So you have to remove it and give to the lab just to make it again just clear. But I think also some kind of problems with acrylic teeth coming off. Mm-hmm. But in my experience, I can say that only biological risks were in place. I had only 2 or 3 fractures of the denture, and they were also temporary dentures. So if we put titanium frame inside, which gives the rigidity, I think no fractures will come there.
Okay, thank you so much.
Thank you.
My name is Emilio Arguello. I am a periodontist. I'm originally from Mexico City. I finished my residency at Tufts University. I spent about 10 years of my life doing research, intense research, so I spent a lot of time studying that bacteria. And when I finished my program, I got invited to become part of the faculty at Harvard University. Now it's almost 20 years since I've been teaching there. In the early stages of my career, I joined the corporate industry, which is one of the largest DSOs in the United States today. Soon after that, I moved to Denver, Colorado, and that's where I practice today. And I joined a private practice. My time had been divided ever since between the corporate world, the academic world, and the private practice world.
Welcome to the Megamind 2026, Season 4, The Road to Toronto.
Megamind is a very good project, and I'm honored to be invited as part of that team because that gives the clinicians, especially the younger clinicians, the ability to foster an unbiased approach and knowledge, and not to become necessarily attached to a product or a system. And also another thing that I praise a lot for the project of Megamind is that they have paid a special attention to the people that judge are not necessarily affiliated 100% to a company and freely judge the cases that are coming through without that attachment to the industry. What am I looking for in that competitive environment? The most important thing is how were you able to serve your patient in the best possible way? Your train of thought help that person's life and improve that person's life. It's also important to think outside the box. If you are able to deliver the correct treatment to your patient, along with an environment that you were able to come around the problem by the open-mindedness of thinking of a potential solution, that makes the case even more interesting.
I am Professor Promchai Chansityanon. I am the Dean of the Faculty of Dentistry, 𝐶𝐿 University, Bangkok, Thailand. My specialty is oral and maxillofacial surgery, and my passion is education, research, and inspiring the next generation of dental leaders. To me, Megamind is not just a competition. It is a place where ideas grow and innovation thrives. I join because I believe in supporting young professionals who dare to think beyond the usual. When I was a student, we didn't have something like Megamind. Global platforms were rare, and opportunities to share ideas internationally were limited. That's why I value this so much. It offers the kind of chance I wish I had. For the next generation, Megamind is a gateway to connect with peers, to learn from mentors, and to share their vision with the world. It is a chance to grow, share, and truly make an impact. The real strength of Megamind is that it combines competition with collaboration. It's not about the winning. It is about learning, sharing, and building a community of innovators. I am looking for finalists who show skill, creativity, and a sense of responsibility. Ideas that are not only innovative, but also have the power to help people in real life. Believe in your ideas, stay curious, be bold, and remember the ultimate goal is to make a real difference in patient care and in our profession. Unlock your potential, test your mind, Megamind.
Didi? It's okay.
My name is Dr. Beatrice Lang. I'm a practicing prosthodontist.
how's the gum and it's healed up, right?
I've been in private practice since 2005. My journey starts with going to dental school here at the University of Toronto. When I graduated, I realized that I was not comfortable practicing yet. So I moved to the States and I did a year of hospital residency at Boston Medical. The 3 years when I was in prosthodontics studying, that's when I realized that what I learned in dental school was not adequate. It was just a lot, there were a lot of missing links. I've always wanted to be able to help people to connect those missing links that were always there. So I got the position to teach back at the same dental school that I went to. So now I've been teaching for the last 6-7 years.
Megamind is a global stage for aspiring dentists to compete for a chance to become the next generation of leaders in implant education.
Megamind Global Competition as an opportunity to improve on my public speaking skills. There was no age limit. At this point in my career, why am I doing it, right? Yeah, to me, it's every opportunity is an opportunity to learn from, whether it's good or bad. Why not just try it? What's the worst that can happen? You don't win. You walk out with new experiences, meeting new people, and I think there's always something good that will come out of this experience. You know, part of me is showing my sons that I'm still learning, I'm not perfect, I'm not afraid to try new things, and that I might lose, and that's fine. I like to do what I tell them to do.
Surgery is the best because I couldn't even imagine doing me endo, prosto, ortho every day because surgery is who I am.
So I went down to the water and found my faith because I don't want to be stuck in.
So hello, my name is Evelina Ginevičiūtė and I'm from Vilnius, Lithuania. Now, why I become a dentist? It's like a funny joke, but when I was 3 months old, so my mother had a lot of dental visits, and after one, as she said, after one painful and, as she said, very expensive appointment, she looked at me at the baby and said, "You will be a dentist." And from that moment, it's natural. Evelina is a dentist, and now I'm a dentist. So honestly, I'm happy, and I'm grateful for my mother because I love what I'm doing. And what I'm doing if I'm not working, so I love food very much, and also I love traveling, exploring new places, and I'm combining it with active activities because my biggest love is water, and I love surfing, wakeboarding, diving, and etc. My personal goal and my professional goal, I still believe that I can manage and I can be a top expert and still live and enjoy life. I think that Megamind is not just a competition. Yes, it's a competition and the winning is not a goal. I think that the most important thing that we are together and we are sharing ideas and creating that big, strong community. So how I'm feeling? I'm happy. I think I'm happy.
Oh no, you ain't seen nothing yet.
Hi, I'm Dr. Mustafa Jamil. I'm a periodontist. I born in Egypt and I spent my whole life in Cairo, Egypt. My private practice, I have 3 clinics and I'm starting all my way working in Egypt. I started my Faculty of Dentistry studying in 2005 and I finished my PDS on 2010 and I started in 2012 after finishing my residency, going with a master degree program, working with my master degree thesis on the sinus lift, trying to dig into the field of sinus lifting, how to do the sinus lift, the open and closed approach. Starting my day early morning at 6 a.m. to have a chance to meet my kids before going to school and taking them to the bus where they go to the school. Then starting my day with a fresh shower and go to mosque to have my prayer, and then I read part of the Quran. Then I take my car and go to the gym. In the gym, as you know, our profession is very, very tough with a lot of stress, so we need to relieve this stress with the gym. After the gym, we have to go to the pool to relieve with the cold. Then I'm ready and fresh to start my clinical day and see my patients. While I'm in the car, I'm starting talking to my receptionist and check do the patients are ready or not, to talk with my team to prepare everything for our day. As you know, the dentist is like a family member. We are trying to build a good relationship with our patients. It's not about money, it's all about reputation, about delivering the best for your patient. Especially when we are talking about implantology, it's not a hit and run. Most of our cases may take 1 or 2 years to finish, from augmentation, soft tissue and hard tissue, temporization, scans. It's a lot of work. So if you don't have the ideal relationship, a clear relationship between you and your patient, you will suffer a lot and the stress will be much more. After that, it's very important to communicate with your team members. To improve the quality, it's not about you, it's about how you're gonna deliver, what your goals as an institution, what the goal of this, how to prepare our patients, how to prepare our schedule, how to make everything comfortable the best way for our patient. Apart from the clinical work, I'm dedicating a very large part from my life for education. We are working with the advanced implant program. We have a lot of young dentists who are aiming to learn implantology from basic to advanced. Regarding Megamind, from where did I know about Megamind? For me, it's a brilliant idea. So you are connecting young implantologists to share their own cases together. It's not only about selling implants, it's about improving the quality of not only dentists but also speakers. So Megamind, they are creating a future speakers. So the idea was brilliant. Why did I apply for Megamind? I found that it's a great opportunity to network with doctors from all over the world, to have a better exposure for new techniques and new doctors, how they are delivering and how they are treating their patient, to learn from each other and sharing knowledge together. Regarding Megamind 2026 taking place in Toronto, Canada, for me, I never visit Canada, so it's a good reason to attend there. But also it's a very prestigious event to share among all these world-class speakers. I would love to share them, and of course, I'm looking forward to be the winner. It's not easy, of course, but I will do my best.
I think that dental implantology should not be a traumatic experience. Should be the opposite. Should be more human, more close and comfortable experience to our patients. My name is Emilio Rodriguez. I am a dentist. I graduated from Alfonso X Sabio in 2003. I'm a specialist in implant dentistry since 2005. For me, becoming a dentist, it was not a sudden decision, it was natural. I came from a family of doctors where patient histories, pathologies, the particular vocation of the medicine is part of our DNA. I grew up in a dental clinic and As a kid, at the beginning was like a game, but I understand that the deep impact of the professions could be in a patient's life. After 2 years graduated, I put my focus on immediate dental implants, especially because I consider and I believe that it's a real aesthetic and functional solution to my patients. This kind of treatment has the balance between efficacy and comfort, thinking always from a minimal invasive approach that guides my daily practice. I discovered Megamind by chance because a really good friend of mine pulled me out of my comfort zone and think that I should apply to the competition. I consider that Megamind is a great opportunity to all of us, true lovers of the profession, that we do everything with passion and without secrets, and share our knowledge and experience, even our mistakes, with colleagues from different parts of the world. My goal in Megamind is pretty clear. It's continuous learning and share my experience after many years of practice, share our life experience and different point of view to trade things, grow as a human and professional.
안녕하세요. 김정주입니다. 저는 치주과 전문의로서 환자들의 잇몸, 구강위생, 임플란트 등 환자들의 연조직과 경조직에 관련된 치과 진료를 전문적으로 하는 치과 의사입니다. 레지던트 3년차 때 참석했던 유럽 오스티올로지 학회에서 수상은 제게 특별한 순간이었습니다. 케이스를 나누고 교류했던 그 시간들은 너무 즐거우면서도 많이 배웠습니다.
you us today. It's a great honor for me to participate in Megamind Continental League. I would especially like to thank the respected jury for this opportunity to present my ideas. I really appreciate this. Today, I want not just to present a case, I want to show you how working on that case has changed my clinical vision and attitude toward concepts. We have a lot of concepts in modern dentistry. We all have them in mind approaching treatment, and it affects our treatment decisions and plans. So sometimes it may be confusing to a clinician, as sometimes these concepts conflict with one another and even narrow your clinical thinking if you are too much in one concept. So when I approach a case, I can look at it from the bone concept perspective, and then I need to only search for a bone to place an implant. And I have a lot of bone, I have to learn how to do this. And then I have another sub-concepts like GBR concept, or maybe only autogenic bone concept, or maybe only synthetic or biomaterial concept. And then another concept comes from like soft tissues and says, doesn't matter, bone doesn't matter, you only need to place nice soft tissues and then everything is fine for you. So, and then another concept says you just need a good timing for implant placement and do right prosthetics and everything is gonna work. So, and maybe another perspective would be the occlusion guides everything, and all you need a good occlusion to guide the TMJ in the right position. So I want to show you a patient who had it all. She's a close relative of mine, so I had a lifelong treatment for her. And he had a fractured frontal incisor in 2015. I removed it, and it took me half a year to heal, to a nice horizontal defect, but it took me a bit more to understand what to do with her because I knew how to augment bone at that time by bone block, but she has 5 different sites to make augmentations, and there was no way I could find so many blocks for her. So I went to Hungary and learned how to do the GBR concept from one very good doctor in there. And I started doing that. And now I came back and I decided to do it by sausage technique as a horizontal defect. I opened the flap for her, and I took a bone block from the nasal spine. I also did the decortications, and I simultaneously did the frontal mandible, but I will not focus on that. I will only focus on the frontal maxilla case. And this time I fixed the membrane, and I also took some blocks from the chin. I crushed all of them into small particles and mixed it 50-50 with xenogenic. This is a way how you can make more out of less. So you take less autogenic and mix it with xenobone, and it works well. I've fixed the membrane in a manner of sausage, very dense under the native collagen membrane, fixed with the pins and sutured everything, releasing the periosteal incision. In 6 months, she came for reopening, and I reopened that. And I liked the healing. There was nothing happening during that period, which I didn't like. So I did a cone beam CT, quite good result for the horizontal augmenting. I opened it and I didn't have any particles. Everything was healed in one good piece. And I was very confident about myself now with this concept. So I can place an implants, and I placed an implants. And then I did one thing which actually I learned in Hungary as well, to contour the protective layer, as the doctor called it, or mini sausage, or creating the positive gingival architecture in this case. So I fixed this mini sausage above the implants because I wanted the best for this patient. And I also placed a connective tissue graft on top, sutured everything, and it was way more than 4 millimeters above the implant shoulder. So that's how it looked like. It looks very nice, very juicy. These pictures are so good, but I distorted the vestibulum in here. And I was not very much in the soft tissue treatment concept at that time. So I did the vestibulum next time. I also learned it in Hungary. So I did the strip technique. That was the only technique I knew at that time. When you do a barrier from a small keratinized tissues for the apical, to hold the apically repositioned flap apically. Nowadays, I would do a small piece of free gingival graft coronally to thicken the coronal part, but I didn't know how to do that at that time. So I placed it, and I immediately started having problems because some pieces and particles of xenogenic bone are coming out of the gum. I probably overthinned it, or I think it's more the problem of having the pieces non-integrated, but having this fibrous integration in the soft tissues, encapsulation. So osteogeneity of the outer layer, in this case, if it's only biomaterial, is kind of very low, because the only osteogenic source in here, I think, will go from the outer layer of the bone, and the distant part would not heal. It will only be a contouring graft. So in this case, you have to do a proper prosthetics, and strip technique maybe is not the best case, best thing in here. So I started opening and creating the emergence profile for these implants. I was searching for the implants, and every time she came, I had these particles popping out of the gum. Every time I had to remove a few particles of the xenogenic bone from there. And I created, in a few months, I created an emergence profile. And as I'm mostly a surgeon, I decided to give her to prosthetic doctor, which I thought is the best doctor at that moment. And she was very into another concept from Vienna, this concept of guided occlusion. And she made, I told her maybe we do this, listen to Thomas Linkevichus, because 2018 he was already a bit known, but she said, all right, I will communicate with the technician. But in a few months later, we ended up with a very, very short titanium basis, which squeezed all this contouring graft into the gum. So that was the way it was communicated, and he was probably not into this concept, and it was not as popular at that time as it is right now. So in January 2012, the COVID came, and we started immediately finishing this total work, and patient was already tired because it's 3 years in treatment for her. So we finished it very quickly, and she was complaining a little bit all the time, and I couldn't find the real reason because there was too much work done in this total rehabilitation. And then she came in August 2024, and now I see the problem. So it was pus coming out from the gum, and I decided maybe it's one pin or something left of the grafts. So I decided to open the flap because the implants were stable, and clean it. And I also decided to remove the crowns. I made injections, and I took the rubber forceps because these were not screw retained. These were cemented crowns. And I applied a slight force on that, and I had the implants on the table immediately, both of them. And you can see how close is titanium base and zirconia to the platform, which means it was all the tissues were squeezed to the platform, and it's not a surprise we have this problem now. I immediately had to do something. And I have two decisions. Leave it for healing because there was an infection and will risk with collapse of soft tissues and very complicated regrafting later on, or graft it immediately and have a bit more risk of soft tissue collapse. So I decided to go for the second choice. And this 10 years has passed now, a bit less, and I have an experience in augmentations and also problems. So I decided to change the concept a bit. So I placed the membrane, and then I placed a xenogenic graft on top of it. And on top of it, I decided to use the outer layer of tuberosity, which is very big in here, as you see, and it's a good opportunity to use it. And it has a lot of molecules which signal to make a bone, and xenogenic graft doesn't. So now I use xenogenic graft only in the intrabony defects, and the outer layer I would try to use autogenic as much as possible, and I fixed it all, and it took me 10 years to go upside down in this concept. So that's how it looks like intraorally. And I also decided not to make periosteal lesion incision, but make a connective tissue graft and leave it for open healing, because it had a lot of connective tissues on the same tuberosity side. I suture it, and in 6 months from that, suture removals was good, a bit of secondary healing as expected here. And yeah, 6 months from that, we have cone beam CT. Tuberosity is always more translucent on cone beam CT, but I can see the contour and I like it. And when you see it intraorally, there's nothing else that supports such an amount of tissues than a bone. So I open it and I have nice, vital, juicy bone. I like it. So tuberosity healed well in this case. I didn't have an infection. It was nice. I placed 2 implants again. And this time I left it for open healing, transgingival healing. And now she came because her lateral fractured, and I decided to do one abutment kind of one time. This is not one abutment one time concept because I installed them in 6 months, but I will not going to remove this multi-unit abutment anymore. So I will not going to mess with the transgingival tissues and contours them with anything. Everything happens from the gingival part. We decided to remove the tooth and leave it for partial extraction therapy to contour and make a cantilever. I ordered bridge with a cantilever, and that's how she looked like this November. And I get first appreciation from her this time. She was not happy before, but this time she said, I don't feel that my occlusion is locked anymore, and I like how it looks much more. So she felt that something was wrong. It's just we didn't find the answer. What was it? So yesterday she came to me. I make some more pictures, and it's stable. It's just 3 months, but that's good for her. Some more tissues fills the defects, and to take home from that, I would say that non-osteogenic outer layer might be a problem if it's used inappropriately. I would recommend transgingival one abutment, one time concept in this case, if you want to contour it with some synthetic or xeno or autogenic or allogenic bone. So, or maybe some polished necks of the implants and transgingival implants. Strip technique was used inappropriately. In this case, I would go for conventional fringingival graft on top, and there was no respect to biologic with prosthetically this time. But there was a time when there was a bit of confusion about concepts. There were too many of them, so I can't blame other specialists too much for that. And occlusal guidance on the implant, I think it's not the best idea because the implants don't have proprioception and don't move don't change their position with time. So I think there was also overforce on this implants. You saw the crowns, they were huge. They were about 2 centimeters, and she never actually had a problems with TMJ to treat with occlusal guidance. But there was another concept that affected the treatment, and some miscommunication between specialists was an issue in this case, I would say. So in the end, I think that concept is good, but we sometimes see the only 10% like an iceberg above the water of this concept, and we need to dive deeper in cold waters to explore other 90% of the concepts and to know it by your own experience, to learn it, to communicate this, and that would be take-home message from this. Thank you very much for your attention.
Recording stopped.
Yeah, thank you for your presentation. So the judges, any comments?
I would have one question for you. First of all, thank you for your nice presentation. Tell me,
Thank you,
please, when placing implants in regenerated bone, do you modify the depth of placement in comparison to the native bone? And if so, what guides your decision?
Thank you. Thank you. This is a very good question. I try to guide nowadays. I try to guide the decision by a biological risk concept of 4 millimeters from the restoration, expected 4 millimeters from the restoration margin. And sometimes, just for myself to feel more better, I try to place implants a bit deeper because I want a platform to be overgrown by bone, and I sometimes expect the graft to shrink a bit, especially in the huge augmentations like verticals.
Okay, thank you.
Thank you for your question.
Okay, Antons, I like how you started telling us about your journey with this case. That's very, very honest. And also how you make us think very intellectual, right? When to use the soft tissue graft and when to go for bone only and when to do it combined. So that's pretty interesting. I agree with your emergence profile that initially was unideal. I think you can support it with some excellent papers that are out there. You can speak about the critical, subcritical zone or ABC according to the papers from Ramon Gomez Meda, or now the group of Ronnie Jung. Also, they have something that just came out there. I just want to ask you, probably you said it, but just to get it concise out there. Why do you think it failed the first time? Has it worked in other patients? Have you changed the approach thanks to the failure?
Yes, thank you. Thank you. Very good question. I think it failed by a combination of factors. One of the factors was, I think, occlusal guidance and these very long crowns. Maybe in this case they should distribute the force by splitting, or maybe it was not really that needed. Because later on I heard opinions and some papers about occlusal guidance on the implant doesn't work well. It just crushes something on the implant because it's very dense, has no proprioceptive connection to the bone as the tooth has. That's factor number one. Second factor, I think my decision to make this contour of the bone, which is not very stable, and not communicating this zero bone loss concept, or maybe having the 2 millimeter titanium base at least, so we don't touch the layer of the bone or contour. In this case, I will not call it a bone. It's a contouring graft. So in this case, it might be a bit better. I think some of my management of vestibulum in this case played some role, because some biofilm probably went in this contouring graft, which in my opinion never heals. It's just encapsulations. So I can't see just one factor, I would say. I think there are a lot of them in here. And yes, it changed my clinical approach, as I was trying to show it in this schematically. I tried to do outer layer of osteogenic, as osteogenic as possible, and I mean autogenic bone on the outer layer, and only intrabony defects are filled with bone substitute materials in my practice now. So I would try to do this real bone on the outside because it has more molecules to signal for the cells to convert into osteoblasts.
Perfect. Thank you.
Thank you.
Those single crowns, right? Having it in one
Yes.
piece, there's some biomechanical advantage. In terms of anterior guidance, what you mentioned, what you believe, can be controversial in some other areas in the world, depending the philosophy, right? So anyway, thank you.
Thank you very much. Thank you.
thank you for the opportunity to make the presentation today. I am an oral surgeon, Marius Svedas, and I will present a case of immediate implant placement in the posterior maxilla. This case was challenging because the tooth had a severe recession on the buccal side, and it required simultaneous connective tissue grafting with implant placement. And I will walk you now through the patient's history, treatment plan, and surgical steps, and a 1-year follow-up. Our patient is a 48-year-old male, and the tooth number 26 was treated endodontically some 10 years ago. And after this time, this tooth became symptomatic, and during examination, a vertical fracture was diagnosed. This fracture was extending to the root canals, and this tooth was deemed hopeless and needed to be extracted. Also, a wide 3 to 4 millimeters recession was present on the buccal side. There was a unilateral crossbite on the left side, but the patient refused the orthodontic treatment proposed and just wanted to proceed with this single tooth implant. We can also see some discoloration on the buccal side of the implant number 21, but this is just a superficial discoloration, and there was no periopocket or exudation at this implant. The patient's periodontal status and general health was not compromised. One of the treatment options for the tooth number 26 could be a tooth-supported bridge, but the neighboring teeth only had minor fillings. Therefore, a bridge was not the treatment of choice that I would recommend for the patient. Here, I would like to challenge the audience and ask all of you to think for yourselves, what treatment would you recommend for this patient if this was your patient? What I was thinking for myself, that we can do open sinus lift. That would be possible, but quite challenging because of this curvature of bone here. Another option would be crestal sinus lift, but we only have a few millimeters of bone here. It's like 3 millimeters of bone, and therefore we could only still place a short implant with a crestal sinus lift approach. I have come up with 3 possible treatment plan proposals for the patient. The first option would be extraction, then wait 3 months and proceed with a sinus lift, either open or crestal sinus lift. The benefits of this plan would be that it does not require a connective tissue graft for the recession, because the recession heals itself during the healing period. The drawbacks would be decreased buccal contour, because during the healing, the buccal contour would not be maintained. Maybe if we did socket grafting, it would be preserved a little bit, but still not the same as during immediate implant placement. Other drawbacks would be that it would require more surgical steps, it would increase the treatment time, and it would also increase complication risk and price. The second treatment option would be immediate implant placement in the middle of the socket with crestal sinus lift and connective tissue grafting. The benefit of this approach would be that there is only one intervention. The drawbacks would be that the crestal sinus lift also carries some complication risks, and connective tissue harvesting increases morbidity, pain after the procedure. Also, very important, when there is such a big recession on the buccal, and if the implant is placed in the center of the socket, there is increased risk that the recession would not heal well and the patient would have a buccal defect after the implant integrates. The third option would be to place the implant in the palatal root position with connective tissue grafting and simultaneous socket grafting. The benefits would be that there would be only one surgical procedure, no sinus lift needed, and we can also place a longer implant, which is a good thing if we are considering immediate temporization on the implant. The drawback of this third approach would be the same as with the second approach, the increased morbidity of the connective tissue grafting. Now let's move to the treatment plan that I chose and recommended for the patient. So the first step would be a traumatic tooth extraction, then immediate implant placement in the palatal root position. This would not require a sinus floor elevation. The implant that I would recommend for this situation would be Megagen's Blue Diamond Deep Thread. The deeper threads would be very beneficial in engaging the remaining bone and providing better insertion torque values and ISQ values. Next, connective tissue grafting would be performed to reduce the recession, and this would also help to preserve the buccal contour. The next step during the same procedure would be socket grafting. This would also reduce the shrinkage of the alveolus during the healing time and would also aid to maintain the buccal contour in harmony with neighboring teeth. Then I would plan to fabricate a temporary crown chair side if we would manage to secure a good insertion torque and ISQ values allowed. This fabrication of the temporary crown immediately also helps maintain the buccal contour and helps to seal the surgical wound. And last but not least, I think this is very important as well, that the patient leaves the room, the surgery room, with the tooth in his mouth, even though it's a smaller one. And next, we would plan to leave all this construction to heal for 2 months and then proceed with a definitive zirconia crown. And now let's go to the surgery. What I did during this procedure, the first step was sectioning the tooth roots. And this sectioning and a traumatic extraction helps preserve the alveolar bone and also the soft tissues. If we perform the tooth extraction in bulk, then would probably fracture some parts of the socket and the gums might tear. As the implant is placed in the palatal root position, this position makes that the bone around the implant is circumferentially all around touching the implant, and almost no part of the implant is exposed. And also very little drilling is needed for this procedure, except a little bit apically, and also if the implant position is if the root orientation is a little bit more to the palate, if it's straight, then we have to drill a little bit the buccal part here to angulate a little bit the implant to the implant neck to the buccal side, so that the screw access hole is within the tooth limits and pretty much in the center of the tooth. We can see that there is a vertical bone defect here on the buccal between the roots. It can be grafted easily in this case. If we place the implant in the middle of the crest here, the part of the implant would be exposed, and also the further to the buccal the implant is placed, the more risk of recession after healing we would have. This is the same concept that we know from the immediate implant placement or delayed implant placement in the aesthetic zone. The implant has to be more to the palatal side to avoid future recession on the buccal. So this concept of placing the implant in the palatal root position, especially in this case where we have vertical bone defect here on the buccal, puts us on the safe side to avoid a future recession on the buccal. Here we can see that the screw access hole on the left photograph is very well within tooth contours, and in the middle photograph we can see what I was talking about on earlier slides, that if we would like to angulate this screw access hole buccally, we need to drill a little bit on the side of the buccal of the palatal root socket. The implant is placed 4 to 5 millimeters deep from the future gingival margin. So here we can clearly see that socket grafting and soft tissue grafting is needed to make the buccal contour in harmony with neighboring teeth, and also to not to have the necessity to place the implant even deeper, because if we place the implant even deeper, we would have very long junctional epithelium on the interproximal sides. Insertion torque was excellent, and ISQ was in the green zone as well, so we could safely proceed with a temporary crown fabrication. It is important to use a high quality composite with a high amount of filler so that it polishes very well, and this excellent polishing reduces the plaque accumulation under the gums and at the border of the gums, and helps preserve bone around the implant. After the composite was cured on the temporary abutment, I proceeded with connective tissue harvesting here on the palatal side near the tuberosity, made a pocket in the gums on the buccal side, and filled the gap between the connective tissue graft and the socket with bone filling material. Then a temporary crown was fabricated. Everything was done chair side, and this way there is no need for impressions, scanning, and there is no wait time to deliver the crown from the lab. It helps sealing the surgical wound, because if a standard healing abutment would be connected, it would end somewhere here, and this area would be lost to buccal shrinkage, and the gums would finish healing, touching the healing abutment, and there would be a concavity on the buccal side. And if we fabricate a temporary abutment which mimics the future margin of the bone of the future crown, then the gingiva and the graft can rest on it and also seal the surgical wound here. There was some connective tissue graft left exposed, just a small portion of it, where the recession was largest because there was not enough tissues to cover it, but this small portion heals on its own without any problems. The donor site near the tuber, this in the end of the mouth, it heals very well, and usually this area near the tuberosity is much less painful than the more anterior sites of soft tissue harvesting. A postoperative CBCT shows that the procedure went as planned. radiographically, the bony contour was fully restored here, and the implant depth from the gingival margin was approximately 5 millimeters, and the implant neck was approximately 4 millimeters palatal from the gingival margin. The bony wall on the palate here is 1 millimeter in thickness. It is debated that the palatal bony wall should be thicker to be able to place the implant in the palatal root position, because it should be viewed as the same as immediate placement in regular position, for example, in the center of the socket or in the anterior single rooted teeth. And that we should not touch this bone on the buccal, and the implant should be a little bit further away from it. But on the other hand, there is scientific literature supporting the notion that it is not obligatory to have palatal bone in the maxilla. This concept is called palatal implant placement in full arch procedures when the maxillary ridge is very thin. The implants are placed intentionally on the palatal side, leaving the very thin ridge intact on the buccal side, and this ridge supports the gingiva. We usually have much less keratinized fixed gingiva on the buccal side compared to the palatal side. And the palatal tissue is always keratinized, and it is non-mobile. And this makes it resistant to recession, and this palatal tissue that is not supported by bone is not more prone to periimplantitis than the tissue that is supported by the bone. In the current case, there is still some bone left on the palatal side, and this current case is far from this palatal approach that we saw in the earlier slide. And the implant is also within the alveolar process and within the tooth contours. Let's also look at the implant depth measurement again. It's approximately 5 millimeters deep. And also we have approximately 4 millimeters of bone left until the sinus. So if this was, for example, an all-in-4 case, and we are placing an implant near the sinus, this 4 millimeter distance from the mouth to the sinus is enough and safe to seal the sinus from the bacteria in mouth. And this depth of 5 millimeters leaves us a safety margin of approximately 1 to 2 millimeters if there would be some gingival recession during the healing period. I would like to emphasize again that for such a complex procedure, every component must be precisely engineered, and this is the case with blue diamond implants, which have designed specifically for immediate implant placement with the deeper threads engaging the bone, and also the 2 millimeter height cuff of the temporary abutment, a narrow profile, concave profile of the temporary abutment helps us avoid pressure on the bone here, and also bone profiling is almost never required with this system.
Sorry, doctor, sorry to interrupt.
Yes?
We already running out of the time.
So the 2 months post-implant placement we can see the reconstructed gingiva on the buccal side. This is the radiograph confirming the 0 bone loss in 2 months. Zirconia crown placement with perfect sealing, and also good closure of the screw access hole. And this is the post-prosthetic radiograph. And the 1-year follow-up also shows the stable crestal bone, the buccal contour that is in harmony with neighboring teeth, and no loss of bone around the implant. And I would like to show once again before and after, and there was only one surgical procedure, and we can see that the buccal contour was maintained and the recession was healed here on the buccal. For example, if we would measure the pink aesthetic score, I think it would score approximately 13 out of 14, just because there is some irregularities here on the buccal, but otherwise the patient is very happy, and he's also very happy that there was only one surgical procedure. But this should be only reserved for very carefully selected cases, and I would not try to do that in the anterior zone, in the aesthetic zone, because there is still some risk of not perfect healing, and here in the posterior we can accept it if it happened, but in the anterior we should be more cautious with that. And the patient was in perfect general health, non-smoker, non-diabetic, therefore this case was possible to perform in one shot in the posterior zone. And if you had any questions, I would like to answer them.
Dear judges and dear audience, I'm thrilled to have the opportunity to be here in the Megagen Continental round. First of all, let me tell you about that dentistry is evolving. We've been through a digital revolution, and one of the biggest advancements nowadays, it's in the field of guided surgery. It's only allows us, not just only allow us to place our implants in a minimally invasive manner, but also offers us accuracy and predictability. To be honest, I'm placing my implants mostly with freehand, but there are still some cases when the time we spend with the planning, it pays off very well. So today, I would like to guide you the history of my patients from traditional conventional restorations to the digital workflow, showing how dentistry evolved. My name is Bertalan. I'm from Budapest, Hungary. I'm a specialist of oral surgery and implantology. In 2018, I had the opportunity to spend 1 year in Mexico City on a scholarship with ITI, but I've learned a lot and I became fluent in Spanish. Saludos a los hispanohablantes. And I still have active roles inside the organization. Approximately 2 years ago, I started to use the Megagen implant and I became a member of MINEC, which was a great milestone in my career. Now you know a bit about me. Now let me introduce you my patient. She's Mary. Actually, she is a best friend of my mother. I know her since I was a kid. She is 75 years old. She's a great cook and she has hypertension and also she has osteoporosis, but she was just taking bisphosphonates for a few weeks and it was a long time ago. And this is her so-called smile. You can see that she was really scared. She was really afraid that some treatment might be needed. And she had a failing dentition. So look it closer, you can see that there was some pus coming out from the gum and the whole rubber restoration was moving. She had no issues with the upper jaw, so she refused treating that one as well. As you can see, this situation stems from the past. This is a metal frame with some acrylic veneering made like more than 20 years ago. But still, she was too scared to care about the aesthetics. She wanted to fix just the lower jaw. So we started with removing the bridge and all the teeth which was underneath was hopeless. So we decided to remove them. But because of bisphosphonate therapy, we had to do this in an antibiotic prophylaxis. And because of that, we decided that we don't do any implant placement that time. We wait for a healing and we chose an early protocol. We had a nice uneventful healing. So we made a CT scan and we decided to do the planning upon that. As you can see, the bone was more compromised on the left side and it was better on the right side. So we decided that we place 2 implants on the left side and 3 implants on the right side. But let's have a quick look on the upper jaw as well. As you can see, she had some problems, but still I couldn't convince her to treat both arch. If you check the CT scan, you can see that the dimensions of the crest are really narrow and also the quality is not so good. And there are some pathology inside the sinuses in both sides. She had some recurrent sinusitis, so sinus grafting was not an option. I remember I was feeling grateful that time that I didn't have to treat the upper jaw because I had no idea how can I achieve stability with these bone conditions. So because of the bisphosphonate therapy, we decided that we want to do a flapless procedure, so go for guided surgery. And if we check the literature, we can see that any type of guidance can give us a better result. One of the interesting things was that for the meantime, we provided her a removable denture and we used that denture for planning, but not in the conventional dual scanning technique, but we placed some markers on the surface and we made a scan with Aura scan and used that STL for alignment in the software. For the implant placement, we used the band-on implant system and a fully guided approach. We could achieve good stability with all of our implants, but what you can see is that the floor of the mouth is quite high and there is not much fixed points for the scanner. So it was not easy to scan, but we managed to do it and we could deliver her a fixed PMMA milled restoration on titanium basis on the same day. So she was really happy that now she had fixed restoration again. 3 months later, we decided that we stick to the conventional technique with an open tray technique. So we placed the impression copings, we connected them, we separated them, and we connect them again to reduce the stress, to have the most accurate impression what is possible. It's a control X-ray with the fitting of the copings, and this is the delivery of a metal ceramic full arch restoration with a cantilever on the left side. But this is not the case I really wanted to show you, or this is not the part of it I really wanted to show you. 4 years later, Mary came back that she was ready to do something with the upper jaw. As you remember, there was a root under the bridge, which I had to remove 2 years before, which was not an easy procedure either, but still she was refusing to touch the upper jaw. But finally she's back and she decided that now it's time that we should do something. As you can see her smile, we can consider that this is a medium smile line with some asymmetry. So an FP1 type restoration was not an option. So we decided we have to do some bone reduction to provide her an FP3 type of restoration. So we started with the planning. We made digital scans. You can see how the bite looked like. And we decided that this time we use the Anyridge system, which in these situations can be a game changer because it has a relatively small core and wide knife edge threads, which is very good to preserve the bone, but also have good stability in soft bone. And we opted for a so-called all-on-4 approach to avoid any grafting. A few images from the planning, you can see the sinus is still problematic. So for the distal implants, we planned an 11.5 millimeter implant using tilted implant using all the available bone. For the lateral incisor on the right side, we planned an implant with a 10 millimeter in length, but remember that we had to reduce the bone to hide the transition zone, so we couldn't place a longer implant. And here is the most compromised area of the whole situation. This is where we had to the area where we removed the root previously. So that was the only place we could place an implant in this region. So we could only plan an 8.5 millimeter in length. And for the lateral posterior implant, we were planning another tilted implant, the most posterior area as well, to use all the available bone. All of our implants had a core with 3.3 diameter and with a hole diameter of 4.5. This is our surgical guide after the printing. These are the situation after the extractions, and you can see the guide inside the mouse. So we were placing our implants through the guide, and we could achieve a very good stability with all of them. So that was a relief that my mom's best friend will have something fixed. We made some bone reduction without raising big flaps. We used some xenograph to fill the sockets, and we made an intraoral scan right after. This is from the software. This time we chose direct screwing PMMA restoration without any titanium, and you can see the situation after the delivery. So she was really happy that she didn't have to use the removable denture anymore, and she can have a fixed restoration. This is a control X-ray, and this is the situation after 3 months. You can see that the soft tissue looked really nice. There was no screw loosening that time. And we continued to deliver her a final restoration. But this time we decided to have a better accuracy with the scanning, that we use the so-called non-calibrated splinting technique, which means that we use some so-called wings, which these ones actually from the Megagen company, that we attach to our scan bodies, and it helps us to guide our scanner all the whole arch. These are the images from the software, and with this technique we could achieve a more accurate scan. This is a control X-ray checking the fitting of the scan bodies, and we also remove the lower restoration to send back to the lab to renew the ceramics to have a more harmonic occlusion. And for the final restoration, we choose the Emax Circuit Prime, which is one of the best materials in the market if it comes to multilayer zirconia. And only there was some ceramics on the buccal part for the pink aesthetics. And this is after the delivery of the restoration. As you can see, the laboratory made a really nice work. So if you remember how her expression was before, and you look at her now, you can see a very big difference. You can see the midline, nice correct, and now she can smile. We made a contour X-ray to check the fitting of the prosthesis, and all looked good. And at the 1-year follow-up, you can see really how this restoration changed her life. We also, at the 1-year follow-up, we removed the restoration. There was no screw loosening. And if you remove, we have a better approach for probing around our abutments, and everything looked very, very nice. We also made a control X-ray, and you can see that all the bone levels were stable after 1 year. So if you remember her expression, her face. Now you can see how it changed with the time. And she only had to spend a few hours without these. So in summary, this is what this case teaches us. Guided surgery allows us to transform our virtual plan into reality in a minimally invasive manner. Thanks to digital tools, immediate protocols, and first of all, the Anyridge system, we can achieve a very stable and good solution, even in compromised situations. And thanks to new materials, such as multilayer zirconia, we can provide our patient a resilient and aesthetic outcome. But let me leave you with one thing. Let me show you a photo. This photo was taken approximately 30 years ago. This is Mary when she was young, and you might notice somebody else on the photo. Actually, it's a younger version of me. So restoring the smile she had when I was a kid is one of the most rewarding moments of my career. And it reminds me that while our tools are changing from analog to digital, our goals has to be the same, restoring the patient, not just the teeth. So thank you for listening, and I hope to see you in Toronto this summer. Thank you.
Recording stopped.
Three bridges on 6 implants, right? Or 4 on 8, right? But I understand that you used only 4 implants, right? So that makes it justified to have an FP2 or a FP3 in that case. I still sometimes with the zirconia, I don't like the outcome of the pink, right? I saw the pink in your case, and it looks acceptable for probably patients, but for specialists, it's not great. And I have the same problem. When I work here in North America, I don't have a good lab, right? But when I work back in Abu Dhabi or Dubai, I have excellent labs, and my pink is just formidable, and my aesthetics is just unbeatable. So yeah, we still depend on our labs. So that's not.
Full arch restorations.
Long-term limitations.
Yes, or drawbacks, or let's say inconvenience, or
well, I would say the inconvenience if you don't have, like, this was a lucky case because she is relatively a small woman, but maybe for like a big guy with big musculature, I would choose something else, like titanium reinforced and then zirconia or some other solutions. So I would say the masticatory force is definitely, and the position of our implants, how big the cantilever. And for instance, if we have like a more palatal position of our implants, then we have a bigger cantilever as well and bigger forces. So in this time, I go for titanium.
Okay, thank you, fair enough. Thank you so much.
Thank you so much.
My name is Emilio Arguello. I am a periodontist. I'm originally from Mexico City. I finished my residency at Tufts University. I spent about 10 years of my life doing research, intense research, so I spent a lot of time studying that bacteria. And when I finished my program, I got invited to become part of the faculty at Harvard University. Now it's almost 20 years since I've been teaching there. In the early stages of my career, I joined the corporate industry, which is one of the largest DSOs in the United States today. Soon after that, I moved to Denver, Colorado, and that's where I practice today. And I joined a private practice. My time had been divided ever since between the corporate world, the academic world, and the private practice world.
Welcome to the Megamind 2026, Season 4, The Road to Toronto.
Megamind is a very good project, and I'm honored to be invited as part of that team because that gives the clinicians, especially the younger clinicians, the ability to foster an unbiased approach and knowledge, and not to become necessarily attached to a product or a system. And also another thing that I praise a lot for the project of Megamind is that they have paid a special attention to the people that judge are not necessarily affiliated 100% to a company and freely judge the cases that are coming through without that attachment to the industry. What am I looking for in that competitive environment? The most important thing is how were you able to serve your patient in the best possible way? Your train of thought help that person's life and improve that person's life. It's also important to think outside the box. If you are able to deliver the correct treatment to your patient, along with an environment that you were able to come around the problem by the open-mindedness of thinking of a potential solution, that makes the case even more interesting.
I am Professor Promchai Chansityanon. I am the Dean of the Faculty of Dentistry, 𝐶𝐿 University, Bangkok, Thailand. My specialty is oral and maxillofacial surgery, and my passion is education, research, and inspiring the next generation of dental leaders. To me, Megamind is not just a competition. It is a place where ideas grow and innovation thrives. I join because I believe in supporting young professionals who dare to think beyond the usual. When I was a student, we didn't have something like Megamind. Global platforms were rare, and opportunities to share ideas internationally were limited. That's why I value this so much. It offers the kind of chance I wish I had. For the next generation, Megamind is a gateway to connect with peers, to learn from mentors, and to share their vision with the world. It is a chance to grow, share, and truly make an impact. The real strength of Megamind is that it combines competition with collaboration. It's not about the winning. It is about learning, sharing, and building a community of innovators. I am looking for finalists who show skill, creativity, and a sense of responsibility. Ideas that are not only innovative, but also have the power to help people in real life. Believe in your ideas, stay curious, be bold, and remember the ultimate goal is to make a real difference in patient care and in our profession. Unlock your potential, test your mind, Megamind.
Didi? It's okay. It's not normal. Do you like it?
My name is Dr. Beatrice Lang. I'm a practicing prosthodontist.
How's the gum on it's healed up, right?
I've been in private practice since 2005. My journey starts with going to dental school here at the University of Toronto. When I graduated, I realized that I was not comfortable practicing yet. So I moved to the States and I did a year of hospital residency at Boston Medical. The 3 years when I was in prosthodontics studying, that's when I realized that what I learned in dental school was not adequate. It was just a lot, there were a lot of missing links. I've always wanted to be able to help people to connect those missing links that were always there. So I got the position to teach back at the same dental school that I went to. So now I've been teaching for the last 6-7 years.
Megamind is a global stage for aspiring dentists to compete for a chance to become the next generation of leaders in implant education.
Megamind Global Competition as an opportunity to improve on my public speaking skills. There was no age limit. At this point in my career, why am I doing it, right? Yeah, to me, it's every opportunity is an opportunity to learn from, whether it's good or bad. Why not just try it? What's the worst that can happen? You don't win. You walk out with new experiences, meeting new people, and I think there's always something good that will come out of this experience. You know, part of me is showing my sons that I'm still learning. I'm not perfect. I'm not afraid to try new things, and that I might lose, and that's fine. I like to do what I tell them to do.
Surgery is the best because I couldn't even imagine doing me endo, prosto, ortho every day because surgery is who I am.
So I went down to the water, found my faith because I don't want to be stuck in.
So hello, my name is Evelina Ginevičiūtė and I'm from Vilnius, Lithuania. Now, why I become a dentist? It's like a funny joke, but when I was 3 months old, so my mother had a lot of dental visits, and after one, as she said, after one painful and, as she said, very expensive appointment, she looked at me at the baby and said, "You will be a dentist." And from that moment, it's natural. Evelina is a dentist, and now I'm a dentist. So honestly, I'm happy I'm happy and I'm grateful for my mother because I love what I'm doing.
Swear you ain't seen nothing yet. So I went down to the water, found my fate because I don't.
And what I'm doing if I'm not working, so I love food very much. And also I love traveling, exploring new places, and I'm combining it with active activities because my biggest love is water. And I love surfing, wakeboarding, diving, and etc. My personal goal and my professional goal, I still believe that I can manage and
Okay. Good morning, ladies and gentlemen. Good evening, good afternoon, depends on where you are located currently. Today, we are going to spin around just one central question. Does more surgery really mean more bone? Stay curious and keep watching. My name is Maros Kopacka. First of all, I'm dad of two beautiful girls. Then I'm oral surgeon and implantologist based in Slovakia. I studied here in Slovakia, where I successfully reached Doctor of Dental Medicine title, and also I successfully degreed my master title in oral surgery and implantology in Austria. I also lead my own course called The Bone Upgrade, where I focus on helping others understanding biological principles and autogenous bone augmentations. Then I also support providing charity-oriented dental care in my hometown. Here's a short video from my course. Okay, but let's dive into the topic. Please take a look at the screen. There are four smiles of two different patients. What do they have in common? They lost about 1.3 grams. What's average weight of upper central incisor from physical point of view. From a psychological point of view, it's even worse. There is no just the smile. There are organs, there is brain, there is heart, but there is also mind. Behind every smile is a face, is a human body, is a mind. And from psychological point of view, I would say they are even heavier. They are heavier, hundreds of kilograms of fear, doubt, hope, anxiety, pain, hesitation, and many more other negative emotions. Okay, so what's the problem? What's the key problem in dental implantology? It's the lack of tissues. The lack of hard and soft tissues. Here are CT scans of these two patients. Do we have enough bone? Definitely not. But how much bone do we really need? We need at least 1.5 millimeter of bone tissue, of living bone tissue, around titanium cylinder, around titanium dental implant. Why 1.5 millimeter? Because 1.5 millimeter is the only guarantee that through the volume can blood vessel come through. That's the only guarantee that that bone will be living. That's the only guarantee that that implant will be stable enough in a time, in the long term. But what's the reason of lack of tissues? It's tissue remodeling. It's biology. It's Mother Nature. If we are 10 here, 9 of us have a problem. Because 9 of us is thin biotype of bundle bone. So what's happening after tooth removal? There is going to loss of vascular supply, because bundle bone is cortical bone in 90% of cases, and this cortical bone has limited blood supply from outer surface, from mucoperiosteum, and from inner surface, from dental sides, from periodontal ligament. It's a tooth-dependent structure, and if we lose the tooth, then blood supply is compromised, and avascular necrosis is happening. So we can expect then, in 9 from 10 patients, extensive bone resorption. And what's the solution? I bet we all agree the solution is bone augmentation. But where is bone augmentation the most necessary, the most needed? Where is missing, of course. But which bone wall is the most vulnerable? The most vulnerable is buccal bone wall, where there is the highest risk of implant exposure and start of perimplantitis. Okay, but which techniques and which materials do we have for bone augmentations? Could we use xenograft? Yes, of course. Could we use allograft? Yes, why not? Or could we use alloplastic? Why not? But why to drive Vespa if we could drive Lamborghini, right? So if we want to reach excellent vascularity of bone graft, excellent immune defense, and short treatment time, short healing time, then we should choose autogenous bone. That's the only and the best material from since the age of dinosaurs through today, and I'm pretty sure next upcoming few more thousand years it will be the same. Okay, so let's have a look now at a chapter, the bone battle. It's not a real battle, it's a very friendly battle, but it's about comparison of two different techniques. Both are autogenous techniques. On the left side you can see bone core technique, so-called carota technique, and on the right side you can see split bone block technique, also called original Curie technique. So we have here our two patients. On the left side is a very similar defect to the right side. So on left side I chose bone core technique. What does it mean? That I took a 3-fine burr, and while drilling with 3-fine burr that implant side, I also harvested a bone core, the bone cylinder, which I then replace buccally where the bone is missing. In that technique, we have very limited chances to adjust then the position of implant. So think twice or 3 times and then cut once. On the right side, you can see harvesting of split bone block technique or bone block from the most sexy area, so-called external oblique line of the mandible. So on the left side, you can see harvested bone core and also pre-drilled hole for dental implant. On the right side, there are fracturing lines, and after intentional fracture, we can see harvested bone block. I very frequently prefer for bone block harvesting some piezo device, because thanks piezo device, it's a very delicate procedure, and there is very limited bleeding, because there is microboiling phenomenon. We have here 2 harvested bone pieces, which we use in the next photographs. Here is bone core trying. I always do it before I open the package with implant. Then I place implant, and here we can see the buccal point of view, the buccal view on exposed dental implant threads. Yeah, there is already that most vulnerable wall, the buccal bone wall, is already missing. So now we have fixed bone core, or so-called carota, with 2 titanium mini screws with big heads, thanks clamping effect. And on the right side, we can see created new contour in split bone block technique. Okay, here is buccal point of view. Do they have some step in common? Yes, of course. We work with autogenous bone, so they have very important step in common, and it is bone chips collection. Because we have to collect some bone chips for later closing and filling up all the spaces with autogenous bone chips. That's the real goal. So we have to condense it properly to close all the doors for possibilities of possible invading fibroblasts. We have to feel one compact unit under our finger. Here is buccal view, sutured wound, and here we are. Here is already integrated bone core with also integrated dental implant, and on the right side we can see integrated split bone block technique, integrated bone graft and split bone block technique with freshly placed dental implant. So we have 3 months delay in this technique right now. But even worse, after second opening, we lost some bone here. But even though it's a very nice bone volume around dental implant, definitely it's enough bone for survival. But is enough bone really enough? No, we are in the most aesthetically demanding region, missing upper central incisor, just one central incisor. So we have to play game also with soft tissues. Next step is harvesting of regional graft from hard palate and creating chair-side our provisional crowns, plastic ones. Here we are. Here are crowns placed into implants, and graft is also sutured buccally. Here we have the situation after maturation of soft tissues, and then I also decided to reshape this buccal surface of soft tissue in the case of split bone block technique. So we are here ready for final prosto. Soft tissues are okay. We have enough bone. We have enough height of soft tissues. We have sufficient width of soft tissues. And here are our impatient patients. So they are looking forward to have a teeth again. So here is color chosen in for dental lab. And here is the fabrication and delivery of final zirconia crowns. So here we are. Here we have fixed final zirconia crowns from side. And our happy patients. Yeah, here are some x-rays, and we have to realize that these patients were a long time without a tooth. They woke up without a tooth, they go to the workspace without a tooth, they had a lot of pain, and now they are treated. Okay, let's sum up this bone battle. Who's the winner? No one. Or both are winners, because both techniques are great, but they have very similar differences, very small differences. Sorry, and they work very well both, but they are one for bone core for very limited bony defects, split bone block for limited defects, but also for big defects. The revascularization is way faster and split bone block technique because there is way bigger amount of bone chips. If we work staged, there is bigger resorption, thanks another opening, a mucoperiosteal flap elevation, and we have to count with always additional harvesting side. In bone core technique, we could harvest from harvesting side, from external oblique line, for example, but in most cases, I harvest from implant side. So, at the end, I would like to emphasize just one point: upgrade the bone and upgrade the thinking. Thank you very much for your time.
Recording stopped.
Okay, thank you for your presentation, Maros.
Thank you too.
So the judges, any comments?
If I may, I would like to ask Maros 2 questions.
Yes.
First of all, thank you for a nice presentation. I am a strong supporter of autologous bone grafting as well. And I was wondering if you have experience using allogenic bone substitute when performing the 𝐤𝐸𝐡 technique. And if so, can you compare the results between autologous and allograft, or when you mix them? I mean, you use both autologous and allograft?
To be honest, I don't have experience with it because, as far as I know, it's not allowed in my country to use allograft. But I know it's worldwide in use. I don't have any experiences, but yeah, basically, I would summarize it like. Yeah, the autograft, the autogenous bone, is the best bone we could give our patient. And all the time, because there are multiple other strategies, how to mix it with xenograft, how to mix it with other substitutes. But all the time, I have my opinion very strong, and I don't want to mix the best material with something less valuable. I don't know if you get it, but if I have a chance to use autogenous bone, I use autogenous bone. If I don't have any chance, then I would try to think differently and try to find another solution for the real patient. But when I have a choice, when I have an opportunity to use autogenous bone and autograft, then I use it definitely.
Okay, it makes sense. Thanks a lot. And one more thing. Did you experience any screw exposure? And if so, how do you manage early screw exposure?
Yes, that's a problem of every single bone augmentation, possible exposure. Yeah, when I switched to small head, with two fixation screws with small heads, the rate is very small. This first technique, bone core technique, then I use this big heads because I use this clamping effect and press this bone core to the residual bone. But yeah, if it's very early, just don't suture it because it's getting even worse. But if it's after maybe 2 months, or even just think about it. And if I would unscrew this screw, this graft will be quite stable or stable enough. Then there is no worry. Just untighten it, remove it, and keep praying. Yeah, but overall, it's a challenge all the time for all bone augmentation. No matter if you work with xenograft or some autogenous bone, bone closure, or some exposure is all the time the thing we have to deal with.
Thank you, Maros. Thank you so much.
Thank you too.
Okay, Maros, I have a couple of questions.
Yes, sure.
Yeah, so here we go. In terms of your emergence profile and your axial contours, how do you prefer to have or design your implant reconstructions? In this case, these were single maxillary central. Do you give any prescription, any indication to the lab, or do you just hope that they get it right, or how does it go?
I always scan also the provisional crown. So I scan the provisional crown in an oral cavity. Then I scan provisional crown itself with outside the oral cavity, and they can use it for some better understanding the emergence profile and the position of soft tissues.
Yeah, and the provisional crown is always made by you, or is made by the technician?
No, it's always all the time made by me. I don't trust anyone. It was just I believe in just in things that are happening in my practice in my office, and very frequently I reshape that crown. Very frequently I change the contour of the crown. Because you know it is the key for future pink aesthetic.
Exactly. And also there's maturation, right, of the soft tissues. So yeah,
Sure.
in order to have it beautiful, you need to manipulate those soft tissues that in prior practice also that takes quite of time, right? There's another question regarding, you do a lot of surgery. What's your take on chlorhexidine? Do you irrigate with chlorhexidine? You don't use it? Do you feel it's an overkill? Do you think it's probably gets in the way, impairs the healing? Or on the contrary, it's gonna keep, the bad bacteria out of the way?
You mean chlorhexidine for what? For like local disinfection after the surgery?
During surgery.
During surgery. I don't use it during the surgery. During the surgery, I use just a saline, and I use all the time. I use cool saline from the fridge.
Okay.
Because coolant solution has to cool, right? And every single bone surgery, from wisdom tooth removal to any implant, I use all the time cooled saline from the fridge, directly from the fridge.
All right, perfect. Thank you.
Thank you too.
Thank you.
Now can we start? Yes?
Yes.
Okay, let's rock. It's a big honor to start and attend in this part of competition, Megamind. It's amazing that we can use AI to translate our language. I'm a big fan of AI, so let's start to speak in my national language, and the MI can translate it. So now I will start to move to speak in Polish. And let's rock. Moja prezentacja będzie dotyczyła interdyscyplinarnego leczenia niepowodzeń implantologicznych w strefie estetycznej z zachowaniem sąsiadującego zęba własnego oraz odbudową tkanek twardych i miękkich. One moment, I couldn't go ahead. Why?
In progress.
What is the most challenging cases to treat? Which one is the word processing at the Continental round of Megamind. Czyli jakie są najtrudniejsze przypadki do leczenia? W mojej perspektywie najtrudniejszymi przypadkami do leczenia są takie, gdzie pacjent zgłasza się do leczenia poprawkowego w sytuacji, kiedy już miał poprzednie leczenie i musimy to leczenie naprawić. Tym zajmuję się od około 15 lat, głównie nakładając nacisk na to, żeby pomóc pacjentom z większymi lub z mniejszymi powikłaniami, szczególnie z zakresu implantologii i ortodoncji. Pacjentkę, którą chciałbym dzisiaj omówić, jest młoda kobieta w wieku 27 lat, która zgłosiła się do naszej kliniki z sytuacji klinicznej, taką jaką widzimy tutaj. Czyli mamy odsłonięcie implantu w okolicach siekaczy 2,2 oraz problemy z koronami protetycznymi w odcinku siecznym, czyli zęby 2,1, 1,2 oraz zanikiem kości przy implancie 1,2. Jeżeli przybliżymy sobie bliżej, będziemy dokładnie widzieli, jak to wygląda. Stan zapalny, dolegliwości bólowe, problemy z tkankami miękkimi. Krótki rzut na CBCT tej okolicy pokazuje nam, jak wygląda sytuacja, jak wyglądają profile wyłaniania, jak wyglądają zaniki kostne, jak wygląda filar zęba 2,1. Skanując pacjenta, dopełniamy całej dokumentacji, plus zdjęć zewnątrzustnych, plus CBCT, plus skanu. Widzimy, że jest to pacjent tak naprawdę kompleksowy. Mamy tutaj problemy ortodontyczne, również problemy zgryzowe, ale pacjentka na samym początku zdecydowała się na to, żeby pomóc sobie i zgłosiła się po pomoc w odcinku przednim. Jakie mamy tak naprawdę opcje leczenia w takim przypadku? Pierwszą opcją z leczenia jest to klasyczna protetyka, czyli usunięcie źle spozycjonowanych implantów oraz usunięcie zęba ze złamaniem poddziąsłowym i stworzenie mostu od 1,3 do 2,3. No jest to rozwiązanie klasyczne, jest to rozwiązanie teoretycznie łatwe, ponieważ trzeba wypełnić również luki między zębami, trzeba odbudować również tkanki miękkie, jednak jak zobaczymy, że pacjentka jest w wieku 26 lat, to tutaj zaczyna się robić problem, z tego względu, że statystycznie jeszcze bardzo, bardzo dużo życia przed nią i tak naprawdę to leczenie, gdzie poświęcamy kły, jest dosyć w dłuższej perspektywie czasu mało przewidywalne. Opcja numer 2, czyli wymiana implantów, reimplantacja, usunięcie korzenia zęba 2,1, czyli założenie kolejnego implantu. Tutaj również doświadczenie kliniczne pokazuje nam, że jeżeli będziemy mieli 2 implanty obok siebie w strefie estetycznej, gdzie widzimy, że pacjentka miała problemy już z poprzednimi implantami, może dojść do zaniku brodawki, mogą się stworzyć problemy i w przyszłości efekt estetyczny może być tak naprawdę koszmarem. Opcja numer 3, którą w takich sytuacjach preferujemy, jest to usunięcie implantów, które są źle spozycjonowane, nie do końca prawidłowo zaplanowane oraz wydłużenie kliniczne za pomocą ortodoncji zęba 2,1, które oczywiście dalej omówię. Pacjentka zgodziła się na naszą propozycję leczenia, stąd tutaj pokażemy cały cykl leczenia tego przypadku i długoletnie nasze obserwacje. Rozpoczynamy od atraumatycznego usunięcia tego implantu. Bardzo ważne jest, żeby usuwając implant, czy to za pomocą trepana, czy za pomocą innych narzędzi, nie zniszczyć tak tkanek twardych, że ich odbudowa będzie jeszcze trudniejsza. Tutaj na zdjęciu po koronie widzimy, jak mocno został oszlifowany kikut zęba 2,1. Implant udało się wyciągnąć, mimo że był to implant jednoczęściowy, który usuwa się dużo trudniej z tego względu, że nie możemy skorzystać z gwintu wewnętrznego do wstecznej rotacji. Na szczęście udało się to zrobić w sposób atraumatyczny. Widzimy profil korony, która cementowana, nie ma prawidłowego profilu wyłaniania i tutaj są duże problemy higieniczne powodujące dalszy zanik tej kości. Następnie, zgodnie z sekwencją, którą od lat stosuję, jest to wykorzystanie degranulacji. Kolejne wiertła oczyszczają nam mechanicznie łoże pod przyszły implant czy pod zębodół oraz wykorzystanie łyżeczek Lucasa z ząbkami i bez ząbków, a na końcu laseru w celu maksymalnej eliminacji bakterii i wzrostu przewidywalności tego leczenia. pierwszym etapie całość zaugmentowaliśmy, wykorzystując sticky bond z pobranego IPRF-a i APRF-a oraz dołożyliśmy tkanek miękkich pobranych z guza szczęki. Był to efekt, jakby pierwszy etap naszego leczenia, który pozwolił nam zmobilizować te tkanki, uzupełnić je. Założyliśmy most tymczasowy z PMMA, który pozwolił nam na estetyczne przywrócenie funkcji pacjentki. Pacjentka mogła dalej się leczyć. Tak sytuacja wygląda po 2 tygodniach. Mamy przewidywalne leczenie po 2 miesiącach. Oczywiście te tkanki miękkie na razie nie są na poziomie odpowiednim. Widzimy zdjęcie RTG pokazujące poziom kości. Sytuacja po 5 miesiącach gojenia. Tutaj bardzo ważne, żeby były odpowiednie wizyty higienizacyjne. Po lewej widać, że pacjentka nie do końca mogła oczyszczać tą okolicę. Ale po zrobieniu zdjęcia CBCT widzimy, że możemy już sobie odbudować, możemy implantować tą kość. Odbudowa jest wystarczająca do implantacji. Każdy zabieg implantacji wykonujemy z szablonem chirurgicznym, w szczególności w strefie estetycznej nie wyobrażam sobie pracować inaczej. Stąd projekt, wizualizacja projektu, tak żeby wlot był oczywiście od strony podniebiennej. Po zdjęciu korony tymczasowej widzimy od powieści oklusalnej, jak mocno zniszczona też jest 1, ale widzimy, że 2 bardzo ładnie ta pozycja nam się odbudowała. Przymiarka szablonu. W Polsce mamy takie powiedzenie, że strzeżonego Pan Bóg strzeże. Zawsze mimo wykorzystania szablonu sprawdzam, jak wygląda orientacja, czy na pewno wszystko jest ok, czy nie zostało zrobione jakieś przesunięcie. Tutaj widzimy prawidłową orientację przyszłego implantu, szczególnie w momencie, kiedy stosujemy tak bardzo małe nacięcie, żeby nie uszkadzać dodatkowo tkanek miękkich. Implant został spozycjonowany w odpowiednim miejscu. Dodatkowa oczywiście augmentacja, kontrolne zdjęcie RTG i tutaj natychmiastowo zeskanowaliśmy pacjentkę. Skan zaraz pozabiegowy stosujemy ze względu na 2 rzeczy w naszej klinice. Pierwsze to jest oczywiście, żeby zrobić koronę tymczasową, to jest oczywiste, ale druga sprawa jest to dodatkowa weryfikacja przez technika, czy implant został w prawidłowej pozycji wprowadzony. Jak widzimy, jest w prawidłowej pozycji. Na bazie mock-upu w EXOCADzie w naszym laboratorium wykonujemy koronę tymczasową. Korona tymczasowa wyfrezowana w PMMA. Czas frezowania to jest między 21 a 23 minuty, więc jest to naprawdę szybki czas. Pacjent odpoczywa w tym czasie w pomieszczeniu relaksu, a my możemy natychmiastowo założyć koronę. Dodatkowe tkanki miękkie, dodatkowa stabilizacja, korona założona. Widzimy, że wlot jest w prawidłowej pozycji, zamknięcie wlotu i teraz czekanie. Oczywiście śródzabiegowo dodatkowa augmentacja, żeby poszerzyć ten profil, żeby ta blaszka przeciągowa była jeszcze większa i następnie po 2 tygodniach sprawdzamy, jak wygląda sytuacja. Powoli się to goi. Korona tymczasowa po miesiącu, korona tymczasowa po 3 miesiącach. Następnie przechodzimy do etapu drugiego, czyli zdjęliśmy koronę tymczasową z zęba 2.1 i przechodzimy do leczenia ortodontycznego, mini leczenia ortodontycznego z wykorzystaniem implantu jako dźwigni. Tutaj niestety informacja, pacjentka zaszła w ciążę, nie chciała być znieczulana, chciała przełożyć całe leczenie, więc przełożyliśmy o okres całej ciąży i okres karmienia piersią. To jest sytuacja, z którą pacjentka się zgłosiła. Na ten czas miała założony most tymczasowy. Sytuacja, jaka wyglądała po tym okresie ciąży i po okresie karmienia. Widzimy, że implant jest stabilny, poziom kości jest stabilny. I w tym momencie zaczynamy stosować ekstruzję ortodontyczną za pomocą specjalnych 2 zamków i specjalnie zaprojektowanej dźwigni. Wyciągamy ten implant z kością. Plusem tego jest przede wszystkim to, że tkanki idą za tym implantem. Ten ząb się wysuwa, uzyskaliśmy 1,5 mm wysunięcia, dzięki czemu obręcz pokazała się i mogliśmy ten ząb włączyć do leczenia protetycznego. To jest skan bezpośrednio przed zrobieniem koron tymczasowych. Widzimy, że mamy całą obręcz, zaprojektowanie korony. Oczywiście wcześniej mieliśmy w innym miejscu zrobioną bardzo mocną preparację, stąd te filary wyglądają tak, jak wyglądają, ale udało nam się je zachować. Tutaj mamy już finalne korony tymczasowe oczywiście, które pozwalają nam dalej formować to dziąsło, dalej wykorzystywać siłę biologii do tego, żeby to dziąsło pięknie nam zaczęło odrastać. Pacjentka już jest młodą mamą i przy okazji jakby widzi to, że leczenie ma sens. Tutaj widzimy przygotowanie już po korony ostateczne. Pacjentka była 4 miesiące na tamtych koronach tymczasowych. Widzimy piękne profile wyłaniania, widzimy to, że udało nam się zachować ząb 2.1 i korona ostateczna na implancie 2.2 i zblokowane korony ze względu na to, że filary były bardzo mocno opracowane i żeby wzmocnić to, połączyliśmy te dwie korony. Tutaj mamy sytuację od strony oklusalnej. Widzimy, jak pięknie udało się odbudować tkanki miękkie. Implant po stronie drugiej pozostał. Pacjentka chciała najpierw zrobić stronę lewą, następnie przejdziemy dalej do strony prawej, ale widzimy, jak na tych paru centymetrach kwadratowych udało nam się połączyć implantologię, chirurgię, protetykę, ortodoncję, po to, żeby jak najbardziej zaoszczędzić tkanki pacjenta. Pacjentka ma obecnie około 30 lat, ponieważ i pozwoli to nam dalej wykorzystywać własne tkanki pacjentki, a nie wchodząc w implantologię dodatkową czy protetykę opartą na zębach 1,3 i 2,3. Tutaj mamy dzień oddania koron, widzimy bardzo ładne spasowanie. Oczywiście korona stara na implancie wymaga wymiany, no ale to pójdziemy później. Jeżeli sobie popatrzymy na radiografię, początkowa po 3 miesiącach, po 4 latach implant jest stabilny, polerowany cyrkon bardzo pomaga tkankom miękkom. Po 5 latach widzimy, jaki uzyskaliśmy efekt. Perfekcyjna brodawka, ekstruzja ortodontyczna pozwoliła nam wyciągnąć ten ząb, wyciągnąć tkanki miękkie i dzięki temu mamy perfekcyjną brodawkę między zębem 2.1 a 2.2, pokazującą tak naprawdę, co udało się zrobić. Zrobiliśmy tak naprawdę jeden mały fragment, ale widzimy, jaka jest różnica, jak to dla pacjentki wzmocniło jej efekt, wzmocniło jej pewność siebie. Na zbliżeniu widać to szczególnie. Widzimy, jak przebudowaliśmy te tkanki, tu były zastosowane 2 przeszczepy, ale to, co najbardziej jakby urzeka w tym widoku po 5 latach, to to, że stosując taką prawdziwą, mało inwazyjną implantologię, można zachować jak najwięcej tkanek pacjenta. Bardzo dużo pokazuje się teraz przypadków All-on-4, All-on-6, All-on-8 u młodych pacjentów. W swojej praktyce stomatologicznej spotykam się na co dzień z pacjentami, którzy w toku swojego życia mają dodatkowe choroby, dodatkowe naświetlania, często są to choroby nowotworowe. Moim zdaniem pozostawienie jak największej ilości tkanek własnych pacjenta, niezależnie czy to chodzi o tkanki miękkie, tkanki twarde, pozostawienie jak najwięcej ilości zębów własnych pozwala nie dość, że tak jak na tym przykładzie osiągnąć piękny efekt estetyczny, to pozwala nam tego pacjenta jakby nie okaleczać w formie takiej, że decydujemy się na usunięcie wszystkiego, bo to, co wygląda fajnie w ciągu 5, 10 czy 15 lat, na pewno mają Państwo, mając jeszcze większe doświadczenie kliniczne niż moja skromna osoba, z własnej obserwacji, jak wyglądają niektóre implanty w strefie estetycznej, szczególnie kiedy ta odległość między implantami jest mniejsza w okolicach zębów siecznych. Tutaj uważam, że osiągnęliśmy super efekt. To jest etap po 5 latach. Obecnie pacjentka jest po 7 latach. Rozpoczęła leczenie ortodontyczne dalsze, więc mam nadzieję, że będę przy jakimś innym konkursie Megamindu mógł pacjentkę przedstawić. Kurczę, czasu było mało, ale się zmieściłem. So thank you very much. And that is the end of my presentation.
Recording stopped.
Thank you for your presentation.
Okay.
The judges, any comments?
Where I can see the... No, I couldn't see any...
Can you see it?
Mm-hmm. Can you ask me here? Because I couldn't see any of them.
Yes, we can ask you.
Okay, that will be perfect. Thank you. Okay.
Hey, Jacob. So you mentioned about removing the implant, right? Doing an explantation dramatically. But at the same time, you also mentioned about using Trifine. Again, I'm reading at the same time that you are lecturing in your native language. So could you please elaborate on that?
In this situation, I didn't use a trepine. I use a trepine only in the area of premolar or molar. Here we use another torque. We keep the implant and try to easily remove. But here everything is go perfect. But normally it's really difficult. So sometimes we have to use a piezo from the front and cut the implant and remove a palatal or front part of the bone to get to the implant, and it's really difficult.
Okay. Seems there's clinicians that we just experience sticky bone and then we love it. Why do you think is that?
I love sticky bone. At first, it's easy to work with them. The sticky bone, make that the graft is like a glue. You can easy work with them. And the second part, the growth factors inside the blood and inside the sticky bone, in my opinion, help us like Professor Chokun said, help us bone to make better bone. I love EPRF, and then I always put EPRF to help healing the soft tissues.
Perfect. Thank you, Jacob.
Thank you.
Thank you, Jacob. I have one question as well. On what basis do you decide whether to preserve or remove an implant when there is a surface exposure, exactly as you have with this lateral incisor?
Could you repeat the question?
Yes, I was wondering on what basis do you decide whether to preserve or remove the implant when there is a surface exposure?
Here in CBCT, we can see that more than 50% of implant is exposure. So I decided to remove them because it's really, really hard to graft with soft tissues, this area, in predictable time. So it's time to, in my opinion, of course, it's time to remove them. It's really easier for me and in my experience to remove something and start from a new beginning, then try to keep the implant with surface in the mouth and try to augment them, transplant again, and it's always compromise, especially when the patient is young. Here we have a 26 years woman, and I know there is a lot of time to make the bacteria added on the surface, and I will have to graft now, 5 years later, 10 years later, and it's not as good, of course, in my opinion, as to start anew in good position, in good planning, and to preserve the situation, but add soft tissues from the palatal or for the tuberositas before and during the implant placement with a new implant with not bacteria on the surface.
Thank you, Jacob.
Thank you.
We can start now.
Good morning, everyone. It's an honor to present my case before you today. It's a true privilege to be here surrounded by such brilliant mega minds and innovators all over the world. Today, I would like to share you something which is really close to my heart, and this is the synergy of biological principles with the modern technology. My name is Marcel Firlej, and today I will present an outside-the-box case using evidence-based yet unconventional digital workflows. My patient is 76 years old male. He presented with 3 hopeless roots, 2 upper premolars and 1 molar. Let's look closer. In the premolar area, we have still some soft tissue volume because there are roots present. But when we look closer, the challenges are clear. We have a massive soft tissue deficiency on the buccal aspect of the molar. The entire root is exposed. But the bone is a bigger problem. We have a sinus step and literally like 0 bone under the first molar. To place implants, we need foundation. And here, this foundation was missing in all 3 dimensions. So my plan was not just to replace teeth, but to regenerate the environment. And I combined 3 key elements. Digital technology to plan a prefabricated immediate load with precise emergence profiles, with immediate implants for both premolars and 2-stage approach for the molar. 2, biological manipulation. I'm planning to use intrasocket reactive tissue to gain soft and hard tissue volume in the molar area. 3, advanced sinus protocols. I'm planning to use osteodensification protocols, Protocol 3, Protocol 1, and the brand new just published Protocol 4. So I designed the surgical guides to place 2 implants in the premolar area, and also the very same guide is going to help me to do my sinus Protocol 3 in the premolar area. And I planned the loading, and immediate loading is going to be splinted. So to manage the molar area, where there was no bone, I designed a digital cantilever. And this cantilever would act as placeholder to guide bone and soft tissue regeneration for my second stage. Now, please take a look at the last radiograph. We need bone. We need bone for the second molar from the distal side of this implant, but also from the top at the apical area. So we started with the extractions. I tried in my surgical guide. And now please take a look at the molar socket. No bone, no soft tissue. Only the granulation tissue. But instead of discarding this intrasocket reactive tissue, I used it. Think of this tissue as a built-in biological seal. It provides stable primary closure even in infected sites. It was a big topic in late 80s, but this is also supported with the literature now. It allows us to work without the need for aggressive flap advancement. By using this tissue, we achieve 3 things. We protect the bone graft, we preserve vestibular depth, and we turn surgical waste into a valuable biological asset for anatomical emergence profile of the molar. So I made the crestal incision on the palatal side, and I pushed this reactive tissue buccally. And this created a chamber. And this chamber is going to hold my graft, and it's going to solve the soft tissue deficiency. Now, for the missing bone, I decided to use osteodensification. Why osteodensification is so safe and effective for the sinus? It comes down to the counterclockwise action of the densifying burrs. That technique simplifies the procedure even in the severely atrophic maxilla. And I documented a few cases in our new protocol with a similar long-term case series study along with my co-authors, my mentor, Dr. Salah Hueis, the inventor of the osteodensification burrs, and Dr. Rodrigo Niva, and this is a brand new article basically from the last month. So, unlike traditional drilling, the reverse motion keeps the irrigation fluid at the very top of the instrument. And as we engage the sinus floor, the fluid combines with the autogenous bone chips, and this creates the hydraulic wave. And this hydraulic wave initially leaves the Schneiderian membrane, but we don't engage too deep. We engage to the sinus literally from this chamber we created at the very first step. So the first entrance point is basically from the extraction socket of the molar, from the side. And using the burrs in reverse, after making initial lift with my hydraulic lift with the autogenous bone and saline, I pushed PRF. Then I pushed allograft, and that helped me to lift the whole structure up. So that's PRF on the top, and that's the allograft as the second part. Now I have a bone. I have a bone between the molar and the premolar. Let's move forward. After gaining the bone with the protocol 4 from the molar axis, I introduced allograft in the extraction socket of my second molar, because there is the place where I need the bone on the very top of the implant. But how can I be sure that I'm gonna not perforate the membrane? So basically, how can I be sure that I'm gonna place my tensile burr exactly in the place where I want? That's the surgical guide. So that's the fully guided sinus lift in the apical area by using osteodensification burrs. Simple as that. Then I placed premolar implants. I fill the molar socket. I fill the molar socket with an allograft. That's it. No membrane. And I loaded premolars immediately with my splinted zirconia provisualization. Please notice, I did not place the molar implant yet. There was simply no bone and no stability. And now please look at the difference. On the top, there is a before, and on the bottom, there is a few days after. We have a new bone volume, new soft tissue, and stable implants. And that's the buccal view 1 week after. 4 months later, please take a look at the tissue. We have a new soft tissue volume on the buccal aspect of the molar and preserved the soft tissue on the premolar area. The reactive tissue, it works. However, after 4 months, in the 76-year-old patient, when there was no bone under the molar is still immature. It's too soft to place an implant yet. I need more time. So I decided to deliver the final zirconia restoration for the premolars, but I kept the cantilever design. Why? Because I don't want to lose this beautiful emergence profile I've created. But this cantilever acts as placeholder, maintaining the space while the bone still matures. But in this case, it's not only the crowns. This cantilever also is going to act as a zirconia surgical guide. And that's the planning stage for the final restoration of my final restoration for 2 premolars and the exactly biocopy of the STL files into emergence profile for my zirconia surgical guide for my second stage surgery. And that's the final restoration placed in place. So I fill up the surgical guide hole with the purple flowable composite because I need to wait a little bit more. And I'm waiting. Another 4 months passed. I overlapped my original digital plan with my new CBCT. So basically, that's the CBCT, the new CBCT I have now, but I overlapped my old planning with the old implant position, marked as green, with the place where I want to have an implant. So to be sure that my original surgical guide from 4 months before in the zirconia cantilever is still in the right position. And I use this reverse engineering. The bone was finally ready. There's like 1 millimeter of bone missing on the top of the implant, but that's not the problem in this case because I'm planning to use osteodensification, and this protocol 1 is going to facilitate the autogenous bone compaction, autografting, and it's going to push the bone to the top of the implant. So I did not remove the premolar crowns. I simply used the tissue punch from the cantilever side in my 76-year-old patient. So to do it as minimally invasive, this is the second surgery, basically. And I used osteodensification protocol 1 to gently lift the sinus floor just a little bit more. That's intraoperative X-ray. And I placed the implant into regenerated bone, purely regenerated bone. And as you see on the first picture, with a perfect stability. Then I placed the titanium temporary tie base. I cemented with the flowable composite, and I closed the access hole also with the flowable composite. This maintained the perfect emergence profile during the integration. 5 months later, the molar implant was integrated. Now I can cut off the cantilever from my final premolar restorations, and I can scan the implant position. Using the very same technique from my previous planning, I can biocopy the bottom of my final crown, final restoration, zirconia restoration, and to copy this shape into final crown restorations with ultra-polished zirconia on the very bottom. And I delivered the final screw-retained restoration for the molar. Here is the result. We started with 0 bone. Today, we have a stable, functional molar implant and beautiful, healthy tissue. What about follow-up? That's 1-year follow-up. Everything was stable and is still stable. We have a very nice bone by using basically allograft and PRF only. And all the implants are within the bone, and that's the 2 years follow-up. Stable bone, stable soft tissue. So that's basically 2 years and actually 1 month follow-up. Nice and stable bone between implants, and now some stable bone around them. So this case was not simple. It required planning. We used digital tools to plan the sophisticated cantilever. We used biology, the reactive tissue, to build up the guns. We use physics, osteodensification, to build the bone. So technology gave us speed to treat the premolars immediately, but understanding biology told us to wait for the molar. And this balance was the key to success. Thank you for your attention.
Recording stopped.
Thank you for your presentation.
Thank you.
So, Professor Kelvin, do you have any question?
Yes, I have some questions.
Thank you.
First of all, congratulations, because you really did something that you thought out of the box. I would like to, yeah, it's a little bit of experimental, but it worked nicely. It's something that you would implement in your practice with other similar cases, or after this experience, you
This
think
is not my single case.
oh, that's where I'm going. Or would you probably think that probably it's not worth it, going through all these, because you spend time designing and all this, right? So some of the older clinicians might think this is a little bit too much of an overkill, but I appreciate what you're doing with the soft tissues as well. You're training the tissues and you're making it more predictable, right? So what's your opinion? What's your opinion?
Yes, I understand. But first of all, we have to think that this is 76-year-old patient. So basically, he didn't really we try to be as minimally invasive as possible. So yes, I agree. First of all, this doesn't have to be zirconia. It could be something like more cheaper. But I wanted to be sure that it's very stable. And you're right, absolutely. I completely agree that it requires some planning before. So it's not for everyone. It's not the only way. It's just one of my ways. So there are many ways to treat this case. I just basically like the digital design. I like playing on the computers. I like doing it. And it's kind of a hobby.
Yeah, could you repeat?
I'm completely right. Completely right.
Yeah. Could you repeat which software did you use? Was it Blender, Mesh Mixer?
No, it was basically a Blue Sky Plan and EXOCAD.
And EXOCAD. Okay, perfect. Yeah, good job. Thank you.
Thank you.
Marcel, thank you so much for your nice and thorough presentation. I have just one question. Do you have any limitations when performing an internal sinus lift using osteodensification burrs?
That's what I described. We described in the new article from the last month. Basically, my limitation, because I usually try to do the sinus lift with the implant placement at the very same time. But to do that, I need 2 to 3 millimeters of bone to get the stability in some kind of cancellous bone, because I don't want it to be locked in the very thick, thin, just cortical part. But if I don't have a lot of millimeters and I have very thin soft tissue, so according to zero bone loss concept, to place the implant a little bit deeper, that's where I usually do two-stage approach, where I have like 1 millimeter of bone or too thin soft tissue volume. Then I do it in 2 stages. And to be honest with you, I do a lot of sinus lifts, and all my sinus lifts are right now through osteodensification. Yes, I know it's controversial, but this is how it is.
Okay, thank you.
My name is Emilio Arguello. I am a periodontist. I'm originally from Mexico City. I finished my residency at Tufts University. I spent about 10 years of my life doing research, intense research, so I spent a lot of time studying that bacteria. And when I finished my program, I got invited to become part of the faculty at Harvard University. Now it's almost 20 years since I've been teaching there. In the early stages of my career, I joined the corporate industry, which is one of the largest DSOs in the United States today. Soon after that, I moved to Denver, Colorado, and that's where I practice today. And I joined a private practice. My time had been divided ever since between the corporate world, the academic world, and the private practice world.
Welcome to the Megamind 2026, Season 4, The Road to Toronto.
Megamind is a very good project, and I'm honored to be invited as part of that team, because that gives the clinicians, especially the younger clinicians, the ability to foster an unbiased approach and knowledge, and not to become necessarily attached to a product or a system. And also another thing that I praise a lot for the project of Megamind is that they have paid a special attention to the people that judge are not necessarily affiliated 100% to a company, and freely judge the cases that are coming through without that attachment to the industry. What am I looking for in that competitive environment? The most important thing is, how were you able to serve your patient in the best possible way? Your train of thought help that person's life and improve that person's life. It's also important to think outside the box. If you are able to deliver the correct treatment to your patient, along with an environment that you were able to come around the problem by the open-mindedness of thinking of a potential solution, that makes the case even more interesting.
I am Professor 𝐵𝐴 𝐸𝐻𝐃 I am the Dean of the Faculty of Dentistry, 𝐵𝐿𝐴 University, Bangkok, Thailand. My specialty is oral and maxillofacial surgery, and my passion is education, research, and inspiring the next generation of dental leaders. To me, Megamind is not just a competition. It is a place where ideas grow and innovation thrives. I join because I believe in supporting young professionals who dare to think beyond the usual. When I was a student, we didn't have something like Megamind. Global platforms were rare, and opportunities to share ideas internationally were limited. That's why I value this so much. It offers the kind of chance I wish I had. For the next generation, Megamind is a gateway to connect with peers, to learn from mentors, and to share their vision with the world. It is a chance to grow, share, and truly make an impact. The real strength of Megamind is that it combines competition with collaboration. It's not about the winning. It is about learning, sharing, and building a community of innovators. I am looking for finalists who show skill, creativity, and a sense of responsibility. Ideas that are not only innovative, but also have the power to help people in real life. Believe in your ideas, stay curious, be bold, and remember the ultimate goal is to make a difference in patient care and in our profession. Unlock your potential, test your mind, Megamind.
Didi?
It's okay. Is that normal? Do you like it? My name is Dr. Beatrice Lang. I'm a practicing prosthodontist.
All right, so Maureen, how's the gum on the, it's healed up, right?
I've been in private practice since 2005. My journey starts with going to dental school here at the University of Toronto. When I graduated, I realized that I was not comfortable practicing yet. So I moved to the States and I did a year of hospital residency at Boston Medical. The 3 years when I was in prosthodontics studying, that's when I realized that what I learned in dental school was not adequate. It was just a lot, there were a lot of missing links. I've always wanted to be able to help people to connect those missing links that were always there. So I got the position to teach back at the same dental school that I went to. So now I've been teaching for the last 6-7 years.
Megamind is a global stage for aspiring dentists to compete for a chance to become the next generation of leaders in implant education.
Megamind Global Competition as an opportunity to improve on my public speaking skills. There was no age limit. At this point in my career, why am I doing it, right? Yeah, to me, it's every opportunity is an opportunity to learn from, whether it's good or bad. Why not just try it? What's the worst that can happen? You don't win. You walk out with new experiences, meeting new people, and I think there's always something good that will come out of this experience. You know, part of me is showing my sons that I'm still learning. I'm not perfect. I'm not afraid to try new things, and that I might lose, and that's fine. I like to do what I tell them to do.
Surgery is the best because I couldn't even imagine doing me endo, prosto, ortho every day because surgery is who I am.
So I went down to the water and found my faith because I don't want to be stuck in.
So, hello, my name is Evelina Ginevičiūtė and I'm from Vilnius, Lithuania. Now, why I become a dentist? It's like a funny joke, but when I was 3 months old, so my mother had a lot of dental visits, and after one, as she said, after one painful and, as she said, very expensive appointment, she looked at me, at the baby, and said, "You will be a dentist." And from that moment, it's natural. Evelina is a dentist, and now I'm a dentist. So honestly, I'm happy, and I'm grateful for my mother because I love what I'm doing. And what I'm doing if I'm not working, so I love food very much, and also I love traveling, exploring new places, and I'm combining it with active activities because my biggest love is water, and I love surfing, wakeboarding, diving, and etc. My personal goal and my professional goal, I still believe that I can manage and I can be a top expert and still live and enjoy life. I think that Megamind is not just a competition. Yes, it's a competition and the winning is not a goal. I think that the most important thing that we are together and we are sharing ideas and creating that big, strong community. So how I'm feeling? I'm happy. I think I'm happy.
Oh no, you ain't seen nothing yet.
Hi, I'm Dr. Mustafa Jamil. I'm a periodontist. I born in Egypt and I spent my whole life in Cairo, Egypt. My private practice, I have 3 clinics and I'm starting all my way working in Egypt. I started my Faculty of Dentistry studying in 2005 and I finished my PDS on 2010. And I started in 2012 after finishing my residency, going with a master degree program, working with my master degree thesis on the sinus lift, trying to dig into the field of sinus lifting, how to do the sinus lift, the open and closed approach. Starting my day early morning at 6 a.m. to have a chance to meet my kids before going to school and taking them to the bus where they go to the school. Then starting my day with a fresh shower and go to mosque to have my prayer, and then I read part of the Quran. Then I take my car and go to the gym. In the gym, as you know, our profession is very, very tough with a lot of stress, so we need to relieve this stress with the gym. After the gym, we have to go to the pool to relieve with the cold. Then I'm ready and fresh to start my clinical day and see my patients. While I'm in the car, I'm starting talking to my receptionist and check do the patients are ready or not, to talk with my team to prepare everything for our day. As you know, the dentist is like a family member. We are trying to build a good relationship with our patients. It's not about money, it's all about repetition, about delivering the best for your patient. Especially when we are talking about implantology, it's not a hit and run. Most of our cases may take 1 or 2 years to finish, from augmentation, soft tissue and hard tissue, temporization, scans. It's a lot of work. So if you don't have the ideal relationship, a clear relationship between you and your patient, you will suffer a lot and the stress will be much more. After that, it's very important to communicate with your team members. To improve the quality, it's not about you, it's about how you're gonna deliver, what your goals as an institution, what the goal of this, how to prepare our patients, how to prepare our schedule, how to make everything comfortable the best way for our patient. Apart from the clinical work, I'm dedicating a very large part from my life for education. We are working with the Advanced Implant Program. We have a lot of young dentists who are aiming to learn implantology from basic to advanced. Regarding Megamind, from where did I know about Megamind? For me, it's a brilliant idea. So you are connecting young implantologists to share their own cases together. It's not only about selling implants, it's about improving the quality of not only dentists but also speakers. So Megamind, they are creating a future speakers. So the idea was brilliant. Why did I apply for Megamind? I found that it's a great opportunity to network with doctors from all over the world, to have a better exposure for new techniques and new doctors, how they are delivering and how they are treating their patient, to learn from each other and sharing knowledge together. Regarding Megamind 2026 taking place in Toronto, Canada, for me, I never visit Canada, so it's a good reason to attend there. But also it's a very prestigious event to share among all these world-class speakers. I would love to share them, and I would, of course, I'm looking forward to be the winner. It's not easy, of course, but I will do my best.
I think that dental implantology should not be a traumatic experience. Should be the opposite. Should be more human, more close and comfortable experience to our patients. My name is Emilio Rodriguez. I am a dentist. I graduated from Alfonso X Sabio in 2003. I'm a specialist in implant dentistry since 2005. For me, becoming a dentist, it was not a sudden decision, it was natural. I came from a family of doctors where patient histories, pathologies, the particular vocation of the medicine is part of our DNA. I grew up in a dental clinic, and as a kid at the beginning was like a game, but I understand that the deep impact of the professions could be in a patient's life. After 2 years graduated, I put my focus on immediate dental implants, especially because I consider and I believe that it's a real aesthetic and functional solution to my patients. This kind of treatment has the balance between efficacy and comfort, thinking always from a minimal invasive approach that guides my daily practice. I discovered Megamind by chance because a really good friend of mine pulled me out of my comfort zone and think that I should apply to the competition. I consider that Megamind is a great opportunity to all of us, true lovers of the profession, that we do everything with passion and without secrets, and share our knowledge and experience, even our mistakes, with colleagues from different parts of the world. My goal in Megamind is pretty clear. It's continuous learning and share my experience after many years of practice, share our life experience and different point of view to trade things, grow as a human and professional.
안녕하세요. 김정주입니다. 저는 치주과 전문의로서 환자들의 잇몸, 구강위생, 임플란트 등 환자들의 연조직과 경조직에 관련된 치과 진료를 전문적으로 하는 치과 의사입니다. 레지던트 3년차 때 참석했던 유럽 오스티올로지 학회에서 수상은 제게 특별한 순간이었습니다. 케이스를 나누고 교류했던 그 시간들은 너무 즐거우면서도 많이 배울 수 있었고, 그 순간부터 글로벌 스피커라는 꿈이 제 안에서 조금씩 자라나기 시작했던 것 같습니다. 이런 경험들을 바탕으로 학문적인 기회도 운 좋게 이어졌고, 제1저자로 총 6편의 논문을 게재하면서 가장 좋은 진료는 무엇인가에 대해서 꾸준히 고민하고 공부할 수 있었습니다. 군의관 시절에는 보철분
So, welcome back, everybody. So this is the end of this nice session we had today. I would like to sincerely thank for your initiative in launching a new edition of Megamind. My sincere thanks goes to Megagen company. This competition is more than an event. It's a brand already. It's a meaningful platform designed to motivate, educate, and identify the next generation of clinical speakers and opinion leaders, of course. By creating such an opportunity, all of the doctors watching closely Megagen are welcome to get involved, because this company is supporting the professional growth, scientific exchange, and excellence within this field, which is called dental implantology. I would also like to extend my appreciation to all the participants. It takes a lot of courage to step forward, to present the work each of us has, and to expose all these clinical cases, which can be significant for many of us on the, let's say, on the this pyramid of learning. Because I do remember myself 12 or 13 years ago when I started with Megagen, how I could take the benefit from older and more experienced doctors that shared their knowledge with us. I wish each of you continued success in your professional journey and encourage you to keep striving for excellence. Thank you all.
The winners are, you need to mention?
Okay, and of course, in the end, the most significant part of this event is the announcement of the names, the three that had the biggest, let's say, impact for today, and the names are Kopacka and Dr. Marcel Firlej. I hope I'm not wrong in spelling the names. So I would like to congratulate you, dear colleagues, for all the good job you did today, for all the information you shared with us, and I'm looking forward to meeting you in person. Thank you so much.
This concludes the Megamind Eurasia Continental round. We hope that today's excellent presentations will also inspire and benefit your daily practice. The next Continental round will be the Europe round, taking place on February 19th at 8 a.m. in EST. We look forward to your continued interest and participation. Thank you very much, and we'll see you next time.